Dr. Pratima Prabhu, along with our convener, Dr. Megha Kamlapurkar, welcome you all to this insightful webinar on thalassemia and pregnancy today on World Thalassemia Day. This year's theme being Empowering Lives, Embracing Progress, Equitable and Accessible Thalassemia Treatment for All, we will explore in this webinar detection, prevention, and current management options regarding thalassemia in pregnancy. But before we begin, let us join together in a prayer song. For this, I would like to invite Dr. Megha Kamlapurkar, Chairman, Genetics and Fetal Medicine Committee, Karnataka State Obstetrician and Gynecological Association, for the inaugural prayer song. Over to you, ma'am.
Thank you. Namaskar. गणपत गजानन अष्टसिद्ध नवविध मूषकवाहन विद्या ज्ञान गणपत विघ्न हरन गजानन गपधनि सानि धप गदप गरे सा गजानन गजानन गजानन.
Thank you, ma'am. Hello?
Yeah, you are audible.
Yes, ma'am. Thank you for that beautiful devotional song, ma'am. It was very, very wonderful. Thank you so much. So to begin with, I would like to welcome our chief guests for today, Dr. M.G. Hiremat, Dr. Vidya Tobbi. Special guests of honor, Dr. Bharati Rajshekar, Dr. Durgadas Asranna, Dr. Rajashri Paladi, and Dr. Suman Gaddi. I would also like to extend a warm welcome to our speakers, chairpersons, moderator, panelists, and the entire team for today. And finally, a hearty welcome to all the delegates who are joining in with us. Now, I would like to request Dr. Megha Kamlapurkar to introduce today's event and our chief guests. Over to you, ma'am.
Thank you, Pratima. Respected Dr. Hiremat sir, chief guest for today's program, Dr. Vidya Tobbi ma'am, Dr. Bharati Rajshekar ma'am, Dr. Durgadas sir, Dr. Rajashri Paladi, Dr. Suman. Today's esteemed speakers, panelists, moderators, and all the delegates who have joined for this webinar, and the Corona Company people, I welcome you all for this program. Friends, I always feel blessed to be an obstetrician, as we have a lot of responsibility and opportunity to take care of the future generations and make them healthy by our knowledge and resources. Thalassemia is a very important disease, and that causes a lot of financial burden, not only on the family, but as a nation. And for rearing a child with thalassemia, it takes about 1.5 to 2 lakhs per year, along with blood transfusion and chelation treatment. And so general average age of this average lifespan of this baby would be 40 years. So we need to spend 15 to 30 lakhs for this treatment, for this life of this thalassemic individual. So it's a huge burden on the family and even the nation. So it's always prudent to save these children from having such births. And it's this today's webinar is going to highlight how we can screen all the population, especially the pregnant women, and how we can be helpful for preventing this deadly disease. And I'm sure today's guest speakers and today's panelists and moderators, they are going to highlight us on what are the practical tips that we have to practice in our daily practice. And once again, I'm very happy that we have good esteemed panelists and talented speakers and panel moderators as well. May I now have the MG Hiremat sir's CV, please? So, sir is right now a principal of Kehar Medical College, Hubli. He is academic council member of Deemed University, Belgavi, former director of Karnataka Institute of Medical Sciences, Hubli. He is director of Hatch IVF Center, Matoshri Women's Hospital, Hubli. He had been a past president of KSOGA and chief patron and founder secretary of KSOGA. He is ex-chairperson of Breast Committee, Foxy, past vice president of Foxy, CEO of Arya Vedanta Scan Center, Hubli. He is passionate member of Karnataka University, Dharwad. He is the past president of Rotary Club of Vidyanagar, Hubli. He is recipient of Millennium Fellow Award for Excellence in Academics by Foxy in 2000. He is Secretary General, Karnataka Medical College Alumni Association, Hubli. And sir is the president of Sri Shanteshwar Education, Religious and Philanthropic Society, Varanasi. Interesting to know, sir. And he is the president of Ranga Vidyaru. So welcome you, sir. Sir is there. We heartily welcome you, sir. Okay, he may join in a few minutes. Next guest is Dr. Vidya Thobe, madam. She doesn't need any introduction. She has been recent past president of KSOGA 23. She is state advisory PCP&DT committee in charge of PCP&DT board of Karnataka. She is chairperson of food. She was a chairperson of food and drugs medical surgical equipment committee of Foxy. She is best committee Foxy award she has received in 2020. She is ICOG Governing Council members 23-25. She is Foxy Champion Awardee of 2019. So many awards on her name, and she is postgraduate and undergraduate teacher for 30 years. Madam will join shortly because of her emergency. She could not join. So may I have next CV, please? May I have next slide? Dr. Bharti Rashekar madam is presently Sahyadri Multispeciality Hospital director in Hassan, and she is the president, very active, dynamic president of KSOGA this year. She also has lot of accolades on her name, so many awards and so many posts. She has justified all of them by her talent and leadership qualities. I welcome you, ma'am. She is our today's guest speaker also. Next one, please. Dr. Durga Das sir is the director of Kasturba Hospital, Tumkur, and he is now president-elect for 24 and 25. He had been a treasurer of KSOGA in 2020 to 22 and past executive committee member KSOGA in 2018 and 20. He is the past president of Tumkur Society of Obstetrician and Gynecology. And he is associate professor in Siddharth Medical College, Tumkur, and consultant in Kasturba Hospital. We welcome you, sir. Thank you for your gracing this occasion.
Shall I introduce Dr. Rajashri madam? Yes. So I'd just like to welcome Dr. Rajashri Palladi. She is our Honorable Secretary for the Karnataka State Obstetrics and Gynecology Association. She's the Dean of Research, KBN University, and a member of IQAC. She's member of Academic Council, KBN University. She's Professor, Department of OBGI at Kalburgi Medical College. She's been a postgraduate and undergraduate examiner at various universities. She has presented papers and guest lecture at various forums. She's been a director and consultant at OBG Aditya Multi-Speciality Hospital, Kalburgi. At present, madam is there, working there. She's been a gold medalist in OBG. She's a GSC team member, represented Rotary International from India to Australia Rotary member. She is the organizing secretary of 25th KSOGA State Conference, Gulbarga. And she is the past president, Gulbarga OBG Society. We welcome you, madam.
Thank you. Pratima, did you call up Dr. Bharti, ma'am?
Bharati madam.
Dr. Rajeshri, I'm
Yeah,
Okay.
we have called.
Yeah, yes, ma'am. I would like to welcome
there.
our
I'm there.
next.
I just joined now. Sorry. Yeah, Dr. Rajeshri, I have joined.
Yes, ma'am.
I am
Yes.
here.
Yes.
I would
Welcome.
like to welcome, ma'am.
Yeah.
I would like to.
Sorry.
Yes, ma'am. I would like to welcome our next guest of honor, Dr. Suman S. Gaddi. She is a former professor and HOD of OBG, WIMS Ballari. She has a teaching experience of over 27 years. She's a treasurer of KSOGA for the year 2023 to 2025. She's a KSOGA EC member North Zone from 2021 to 2023. She's the organizing chairman of KSOGA 2019 held at Ballari. She's a past president of Ballari Obstetrics Society 2011 to 13, and she's backed the President Rotating Trophy and the Durusha Trophy during the AICOG Mumbai 2013 during her tenure. She has a number of publications in international and national index journals. She has presented papers in national and state conferences and backed prize for best paper presentation in 1994. She is former site principal investigator, facility lead for international research projects, and her area of interest is preventive oncology and high-risk pregnancy. We welcome you, ma'am.
Thank you so much for the kind introduction.
Shall we move on to the first session, ma'am?
Yeah, sure.
Megha, ma'am?
Yeah, Bharti ma'am is there.
Yes.
Dr. Megha, just give me just 2 minutes to reach my office so that I can open my PowerPoint. Meanwhile, you can introduce the chairpersons and do that. By the time I will reach.
Sure.
Yes, ma'am. So our
You can
first.
continue.
Yes, madam.
Just to share my PPT, I will just require 5 minutes time.
Yes, ma'am. So we have the first lecture for today, the topic being hemoglobinopathies in pregnancy. So it is one of the very interesting topics, and we have speaker Dr. Bharati Rajshekar. She is the president of KSOGA at present. She is going to give her valuable insights and a lot of information on this topic. To chair this session, we have Dr. Rajeshri Palati. She is Honorable Secretary, KSOGA Society. Madam, Dr. Rajeshri ma'am, so I would just like to invite you for this session.
Yeah, thank you,
And
Dr.
please invite
Pratima.
our speaker for the session. They're ready. Yes, madam.
It's
So we have
indeed a great pleasure to introduce and chair the session by our dear President, Dr. Bharti Rajshekar ma'am. We all know that Bharti has been a very vibrant personality and has been accomplished obstetrician and administrator in various posts. Madam is this practicing at Sahyadri Multi-Speciality Hospital, which was Bharti Nursing Home, President of Karnataka State OBG Association now, KPME State Vice President and Indian Red Cross Hassan Director. She has organized the first FOXY Satellite Conference in 2006 in Hassan, organized the Red Alert Workshop with Dr. Pankaj Desai from the Hassan Master Control Facility, organized the KSOGA State Conference in 2010, FOXY Public Awareness Committee South Zone Coordinator, FOXY Preventive Oncology Committee and member of the FOXY Food and Medical Equipment and Drug Committee, trainer for FOXY Dhira program, trainer for FOXY RAC program, trainer for FOXY HPV vaccination project, IMA State Past Vice President, IMA DWE EC member, Hassan Past President, Hassan OBGYN Society Past Secretary, and Hassan PCPNDT Committee member. Her special interests are of non-communicable disease and special interests are adolescent health and high-risk pregnancy, preventive oncology, geriatric health in women, family welfare, contraception, and many. We have seen the varied personalities of Madam being involved in many committees and many activities and has been on the forefront of Hassan OBGYN Society and has won many prizes for her committee and for her society. She won the President Medal Topper. She was the President Medal Topper in Final MBBS in Madras University. FOXY President Rotating Trophy as Secretary. DK Tank Award twice as Hassan OBGYN Secretary and President. Faculty at various state, national conferences and actively involved in adolescent health awareness programs. conducted the first aid and basic life support workshops for public, drivers, and colleges, and the presiding rotating trophy as President HSOG member. She's all over the news in Hassan all the time whenever there is a social cause. And recently we have seen Madam addressing the, the media as well to raise a social cause. And most interesting has been the one which I admire her most for her adventurous activities. And she had been to Antarctica recently with wonderful trip and memories. And we have seen the adventure side of her, always on move and gathering it all from the nature and whatever she could best with both the hands. So over to you, Bharti ma'am. I took a time so that you settle down in your OPD and open up your laptop. We are all waiting to listen to you.
Bharti ma'am, please let me know once you're ready. I'll stop sharing my screen and you can start sharing.
Yeah, so a very good evening to all of you. And well, on a World Thalassemia Day, I would not like to be happy about it. Rather, I would say, let us have a Thalassemia Awareness Day, because there are a lot of messages on the web which are saying Happy Thalassemia Day, but definitely there's nothing happy about it. So today, the theme for 2024 is Share and Care. So at the outset, my apologies for being late. But the reason I was late is we had our KSOGA conference committee meeting going on for about 2 hours. From 3 o'clock, we were in the meeting deciding on all the topics and the venue and all those things. So I would like all of you to please block for November 8th, 9th, and 10th. We will be having academic bonanza along with a lot of cultural and culinary feast at Hassan. This is a formal invitation to all of you from as president of KSOGA as well as from and also along with that, just give me 2 minutes. My Zoom has to be opened. Okay. I'm sorry. I'm very sorry. So we are having the conference on the 8th, 9th, and 10th of November, and we will be sharing the details shortly. So I request you to all mark your dates. And today the topic given to me by Dr. Megha, and I again congratulate Dr. Megha also for taking up this very important topic, because these hemoglobinopathies are few topics. I think somewhere, though we know about it in the back of the mind, how many of us think that we are actually screening our women when they come to us, or do we even think of hemoglobinopathies? We are always thinking of iron deficiency anemia. Then, of course, we know that
Ma'am,
Video is stuck.
ma'am is not audible.
my net is very slow. That's my TAs.
Ma'am can put off her video.
Ma'am, you are not audible, ma'am.
Something happens.
Yes.
So
She's rejoining, it seems. And ma'am is trying to rejoin, it seems. And then we welcome Dr. Shanta Duge ma'am, who is the chairman of Public Awareness Committee, KSOGA. Welcome you, ma'am.
Madam, till Bharti Madam settles down, I want to bring 2 things to the forum.
Okay.
My dear KSOGA family members,
Yeah.
especially my special compliments to Dr. Megha and another convener, Dr. Pratima. You know, I am congratulating for 2 reasons. One is today is Thalassemia Day. See, I had seen 3 webinars in my list. Today I am coming from Bangalore attending one of the scientific activity. None of them were talking about thalassemia. So for that reason, Megha, you have selected thalassemia
Thank you, sir.
topic on the day of thalassemia. This is the real sensible day you have chosen this. That's the first thing. Second thing, this is the first time in the webinar anybody is singing the inaugural song. Every time they used to put the recordings. I was really happy while listening to it's a live song you are singing. It was very melodious.
Thank you, sir.
Every time you see all the webinars, they will put the lamp and they will put the recordings. You are the first time you could hear the live song from you. So the second point of congratulations for the things, and very beautifully arrayed subjects, beautifully the panel, everything. I cannot take each one's name. So these two things I wanted to bring to your notice. Now I'm coming from a scientific session from Bangalore. No one was talking about thalassemia. So sensibly you have chosen this topic, both of you. So special compliments to you. With these few words, all the best to the whole event. Shantadurga madam, good evening, madam. Over to Bharti madam,
ma'am
if
has
she is.
helped us, sir, today to get 2 ICOG points for this webinar, sir.
Oh, great. That's a good effort.
We are really thankful to
Yeah.
sir.
Thank you, sir. Thank you.
If Bharti madam is ready, I think she can take over.
Madam Secretary, can we ask other speaker?
Dr. Shobha.
Bharti madam is calling up. For XT, madam. If you are XT. For XT. FUR. FUR XT. For XT. Time is rejoining.
Yes. I'm extremely sorry for this delay. It has never happened to me. I'm sorry. I bring greetings from the Karnataka State OG Association, and as the president of 2024, I congratulate Dr. Megha for having these wonderful topics on this World Thalassemia Day. And let us, without the introduction has been set, and I will be sharing my screen now. Can you allow me to share the screen, please?
Little louder, madam.
Yeah,
the voice is different.
Host has to give me the permission to share my screen. So hemoglobinopathies in pregnancy, as we all know, is quite common, especially in India. And no, I'm not able to share my screen.
The voice is little low, ma'am.
I'm not able to share my screen.
Pratima, can you help her?
Yeah, I have stopped my share, madam. I
Yeah,
think he has to
host
access.
has disabled screen sharing. I'm
I
getting.
will tell him. Yeah, I have stopped my share, ma'am. I'll tell him to give access. He's the host.
Disabled, it says. So the most common hemoglobinopathies in which we are going to talk about today is one sickle cell anemia and the other one is thalassemia. And we know that we already have thalassemia with, no, I'm not able to share my screen.
Yes, ma'am. I'm just calling him up. One minute.
Sure. It says host has disabled me. So today I think in today's clinical practice, it is very essential for us to include screening for hemoglobinopathies in pregnancy, because we do see quite a high incidence of hemoglobinopathies of sickle cell anemia and thalassemia in our country, and especially in our region also.
You can try sharing, ma'am. Share. Just click on the share screen.
Now it's fine.
Yeah.
Sludge. Is it visible?
It is start. Yes, yes, ma'am. Yes, we can see now.
Is it a slideshow?
No, not slideshow.
Click there, ma'am. Yes.
It's not going on to slideshow. Yes. Right. So the topic given to me by Dr. Megha was hemoglobinopathies in pregnancy. And well, I bring greetings from the Hassan city with the cultural heritage of our state. And I request all of you to mark your dates. And so World Thalassemia Day is celebrated on 8th of May. And this year's theme has been Be Aware and Share and Care. So let us be aware of hemoglobinopathies and let us try to care for all these women and couples who are suffering from these distressing hemoglobinopathies. So I will be talking about two types of hemoglobinopathies, but before that, let us understand what is this hemoglobin. So hemoglobin, as you know, is all a complex of heme plus globin, that is a protein molecules. And heme is an iron-containing complement which has two ferric chains, which is connected by 4 pyrrole rings, and one heme molecule binds to one oxygen molecule during the oxygen transport mechanism. Okay. And normally in adults, after the age of 6 months, most of the hemoglobin is going to be hemoglobin A. That is around 97%, and very few of them will also have a complex called HbA2. And the fetal hemoglobin in adulthood will be less than 1%. So what is this HbFA and A2? So well, you know that the heme complex has 4 globin chains. HbA, that is 2 alpha and 2 beta globin chains. So there's basically alpha and beta, delta and gamma chains. HbA will have 2 alpha and 2 beta chains. HbA2 will have 2 alpha and 2 delta chains, and HbF will have 2 alpha and 2 gamma globin chains. And this hemoglobin synthesis is controlled by 4 genes. That is the alpha chain by 4 genes and the beta chain by 2 genes. And the alpha chain genes are got 2 from each parent, and the beta chain genes are got 1 from each parent. So that is the structure of hemoglobin, and these abnormalities can lead to hemoglobinopathies, whether it can be structural abnormalities or it could be functional abnormalities. So as you see the alpha, the beta, the delta and the gamma chains, you see that the alpha chain in fetal from the 10 weeks in utero is constant, whereas the delta, the gamma, which is the fetal hemoglobin, falls as the baby reaches 40 weeks, and at 6 months, after 6 months after birth, it is almost negligent in the adult hemoglobin type, and the beta chains start rising soon as the baby is born. So now we have these hemoglobinopathies, which are a group of recessively inherited genetic conditions affecting the hemoglobin component of the blood. They are caused by genetic changes, that is a mutation in the hemoglobin. They are not X-linked or gender-linked. They are more prevalent in some parts of the world. For example, sickle cell disease is very common in West Africa and India. Thalassemia is more common in Asia and the Mediterranean countries. So what are these hemoglobinopathies? As I already told you, unusual genes that affect the quality and structure of hemoglobin. That is sickle cell hemoglobin, HbO and HbE. Whereas we have unusual genes that affect the quantity of hemoglobin. That is HB, that is alpha hemoglobin, or is it beta hemoglobin, or it is fetal hemoglobin. And that is thalassemia alpha and thalassemia beta. That is the quantity of hemoglobin is varied, and the structural abnormalities, the commonest is the sickle cell anemias. So as I already told you, defect may be in the globin chain synthesis, which can lead to thalassemia, and there is a structure of the globin chain altered, which can lead to sickle cell disease. And usually these abnormalities may be homozygous. If they are inherited from both parents, they become sufferers of the disease. But if they are heterozygous and they carry only one gene from the parent, they only will be a carrier, or they have a trait of the disease. They will generally not suffer from the disease. So you know that these hemoglobinopathies are heterozygous. So the father and mother may be carrying the trait, and with their offsprings, at least 25% of them may have the disease, 50% of them will be carriers, and 25% of them may remain unaffected. So this is the inheritance pattern of hemoglobinopathies, and that necessitates a prenatal or even a pre-marital screening of individuals, so that we see that no two individuals with the trait or no two individuals with the disease enter marital alliance or have children, because definitely they are going to have a percentage of children who are going to be affected by this hemoglobinopathy. So coming to sickle cell anemia, it is a autosomal recessive condition. There is a defect in the beta chain. The normal amino acid at the 6th position of the beta chain is glutamic acid, which has a negative charge. In sickle cell disease or trait, the glutamic acid is replaced by valine, which has no charge. So that becomes sickle cell hemoglobin. So the sickle cell disease is because glutamic acid can also be replaced by lysine. So you see the primary normal structure. In the 7th position, you have glutamic acid, but here it has been replaced by valine. So when it is replaced by valine, you get sickle cell hemoglobinemia. Normal hemoglobin, the proteins do not associate with one another and they carry oxygen very freely. However, in sickle cell hemoglobin, the proteins get aggregated into a fiber, and hence there is a decreased capacity to carry oxygen, and thence leading to all the eventualities. So if you have a mother and a father with a couple with sickle cell trait, they have a 25% chance that they have a normal child, a 50% chance that their children will be sickle cell carriers, and a 25% chance that they may have an offspring with sickle cell disease. Hence, antenatal screening is essential. So what happens in sickle cell anemia, you all know, there is this HbS, there is more than in sickle cell disease, there is almost 90% of sickle cell hemoglobin. That is where the glutamic chain has been replaced by the valine chain. Whereas in sickle cell trait, there is HbS 60% and Hb adult hemoglobin 40%. So they are not much affected by the disease and they usually have a normal life. So the disease burden is tremendous in India. Screening in, especially in tribal areas and in certain parts of Karnataka, has shown that we have the highest prevalence of sickle cell disease, very prevalent in the tribal population and low socioeconomic status, and of course because of the high incidence of inbreeding in our country. So you see this belt running across Maharashtra, Andhra Pradesh, and we have this belt in Karnataka and Tamil Nadu, where we have a huge tribal belt where HbS is very, very common, and HbE is common in the northeastern states. So the inherent pattern, I've already told you, if the parents are HbS, all the children are going to be affected, whereas if they are carriers, 25% are going to be affected. So we have to remember this. So what happens in sickle cell disease? When deoxygenated red cells containing hemoglobin S, they undergo sickling. So there is a sickling and aggregation of the hemoglobin. Constant sickling and sickling damage the cell membrane and its shape may become irreversibly sickled. The cells under hypoxia can become deoxygenated and permanently sickling can occur, and events that show erythrocyte transit through the microcirculation include there will be addition to endothelial cells, erythrocyte dehydration, and vasomotor dysregulation, leading to a lot of pathological changes. So what happens under stress conditions like deoxidation, acidosis, and HbS concentration? There is HbS polymerization, and there is a shift in the hemoglobin leading to RBC additions, RBC rigidity, and hemolysis. So RBC rigidity and addition will lead to endothelial damage. Hemolysis will lead to decreased hemoglobin and anemia. Endothelial damage can set up a coagulation pathway activation and an inflammatory pathway activation, leading to vaso-occlusion and the painful crisis, respiratory issues and neurological issues in these individuals. And because of anemia, they have tissue hypoxia, leading to multi-organ damage, early death, and pain. So this is the pathophysiology of sickle cell anemia. And the degree of intravascular hemolysis will depend on the ratio of HbF to HbS. HbF will prevent aggregation, and hence in the neonate, when the baby has a higher percentage of HbF, you will not notice the sickling. But as the HbF concentration reduces, the baby starts developing symptoms of sickle cell anemia. So sickle cell anemia in pregnancy, if a woman with sickle cell disease is pregnant, she falls under a high risk pregnancy. And if it is a sickle cell trait, so she is a heterozygous carrier, there may not be much complications except for anemia and asymptomatic bacteremia. So what are the effects of sickle cell disease on pregnancy? They can lead to maternal and fetal complications. Maternal, there are high incidence of preeclampsia because of endothelial damage and vaso-occlusion, eclampsia, pyelonephritis because of multi-organ damage, nephropathies and anemia, placenta previa because again due to the microvascular alteration in the microvascular circulation, premature rupture of membranes, premature labor and any acute anemia event and increased incidence of maternal mortality. Fetal implications are there's a high incidence of miscarriages, stillbirths, small for gestational age and premature births. And the mother and the fetus will also be altered not only with these, the mother can have high incidence of neurocognitive dysfunction and strokes, acute chest syndrome and embolism, sickle cell hepatopathy and sequestration and gallstones, papillary necrosis in the kidneys, acute necrosis, avascular necrosis in the kidneys, vaso-occlusive crisis and bony pains, fetal growth restriction and perinatal and neonatal death, and splenic infarction, sequestration, along with preeclampsia, hypoxia, and septicemia. So you know now that what a lot of trouble if undiagnosed sickle cell anemia can cause in this pregnant woman. The clinical features are usually they will be anemic, and any woman who is not responding to supplemental iron therapy, especially if she is given parenteral iron therapy, please suspect hemoglobinopathies. Any woman or girl presenting with recurrent painful episodes of abdominal, chest and bone pain, suspect hemoglobinopathies. In late pregnancy, if they are anemic and they are not responding and they have associated thrombophlebitis, hypertensive disorders and anemia, please think of hemoglobinopathies. And there may be an increased incidence of jaundice, then think of this. And of course, if she has splenomegaly, you have to think of hemoglobinopathies. So the effect I've already spoken to you. What are the effect on pregnancy? It can also cause abortions, abruptions, and there is an increased incidence because of cesarean sections, not due to sickle cell anemia, but due to the associated obstetric complications. To the risk to the fetus, if both parents are homozygous for HBS, there's 100% risk the baby is going to have HBS and it may not survive beyond 12 months to 24 months. If one parent is homozygous, there is a 50% risk. If both are heterozygous, we know that there is a 25% risk, as I already told you. And these are the implications I already spoke to you. And again, it is the effect of pregnancy on sickle cell disease. They will have a lot of vaso-occlusive or painful crisis situations because of tissue hypoxia and vaso-occlusion. So if they do complain of this painful crisis, please treat them immediately and beware. And you have a checklist of how to treat women in pregnancy who come with acute painful crisis. I will talk that later. And then of course we have something called an acute chest syndrome because of the vaso-occlusive injury, and there's an acute lung injury, and it will also show clinical and radiological evidence of consolidation, elevated temperature, cough and pleuritic chest pain, and this hypoxia which may be so severe that leukocytosis will be there, there will be anemia. They may have neurological events like seizures may be there, thrombotic cerebrovascular accidents can be there, and hence the RCOG guidelines are any woman with sickle cell disease should be put on thromboprophylaxis from 28 weeks and for 6 weeks postpartum. Venous thromboembolism is very, very common in sickle cell disease. So because of the hyperviscosity of the blood, so try to always keep the target from 8 to 10. Do not try to go beyond 10 grams of hemoglobin in these individuals because hyperviscosity will make them more prone for thromboembolic catastrophes. And always start them on thromboprophylaxis with heparin and aspirin. And if you have started thromboprophylaxis, it should be continued 12 weeks postpartum. So how do we diagnose? Laboratory investigations, a complete blood count and a peripheral smear is very essential. So all women who come to us in the first trimester, please try to do a complete blood count and not just a hemoglobin estimation and a peripheral smear, because that could give us the blood picture so that we can categorize the women whether they are iron deficiency anemia, whether they are B12 deficiency and folate deficiency, or they may have a hemoglobinopathy. So as you know, she will be anemic. Her retic count is going to be very high. Bilirubin may be high. ESR levels, because the lower RBCs are sticky and less soluble, will be altered. Peripheral blood smear will show these type of sickling cells. And of course, the gold standard for diagnosis is going to be the high performance liquid chromatography. And we all know that in the next sessions we'll be talking that I think this estimation of hemoglobin electrophoresis has to be in our antenatal protocol now, just like we do the thyroid estimation, TSH and the OGCT. I think we have to start doing the HPLC chromatography for all our women who come in early pregnancy, so that we can rule out hemoglobinopathies, that is thalassemia and sickle cell, and proper antenatal counseling, prenatal diagnosis and management can be done. So these are the two tests which are generally done, that is the high performance 10 minutes liquid chromatography or isoelectric focusing. Generally, we do the high performance liquid chromatography, which can identify not only sickle cell disease, you can also identify thalassemias here. So what are the results in the HPLC? The WBC count in sickle cell anemia will be increased. They will have leukocytosis. The RBC count will be decreased. The HB count will be decreased. Hematocrit will be decreased. Reticulocyte count will be increased. HB electrophoresis, you will see HBS and HBF will be there. HBA will be reduced in these women. Urine analysis may show casts because of the nephropathy. Serum bilirubin will be increased in those with sickle cell disease. Platelet count will also be increased. And on bone marrow examination, we will see increased red cells in women suffering from sickle cell disease. So these type of lab parametric charts will help us clinch the diagnosis. So what is the prenatal care for sickle cell disease? Genetic counseling is what is going to reduce the incidence of sickle cell disease in our country, so that we can prevent inbreeding and prevent marriages between heterozygous carriers. So in Bihar, in Maharashtra, they have a prenatal, pre-marital counseling and premarital checking of the hemoglobin pattern, so that they can advise them not to get into marital relationship. Always check the husband also for a hemoglobinopathy. Discuss the risk of transmitting the sickle cell disease to the fetus. Explain what availability, pre-implantation techniques and prenatal diagnostic techniques we have with them. So, and the other one is, what do we do in pregnancy? If she is already having sickle cell disease, educate them about the inciting factors of sickling, that is hypoxia, cold temperature, dehydration, stress and infection. Especially in early pregnancy when they have hyperemesis, you have to be very, very careful. And the baseline investigations, as I already told you, blood pressure monitoring, hemoglobin, hematocrit you will be doing. And of course, I've already spoken to you about serum ferritin, you've got to do it. You have to do the renal function test and of course the retinal examination. If her sickle cell is worsening during pregnancy, please get her fundal examination. Pulmonary lung functions are not always recommended unless she does she just presents to you with any sort of altered lung function. You will ask for lung function tests. Okay. Echocardiography also is not routinely recommended in all females, but however, if they are symptomatic with pulmonary hypertension, asymptomatic with history of pulmonary embolism, asymptomatic with acute chest syndrome, asymptomatic with resting hypoxia, please ask for an echocardiogram. But nowadays, I think it is a wise practice to get an echocardiogram for all your pregnant patients in the third trimester of pregnancy to rule out cardiomyopathies also. So in these sickle cell women, increase the number of visits, frequent blood testing, and try to keep the target more than 8 and less than 10. Never increase it more than 10. Iron supplementation only will depend on your serum ferritin levels. Do not give iron supplementation as a routine to them when the serum ferritin levels are high. Do not give oral iron. You can just treat them with folic acid and B12 and trace elements and nutritional advice. Do a urine culture in every trimester. Treat asymptomatic bacteriuria. If the patient is an aspirin and heparin, continue that. If the patient is not an aspirin, please try to start at the 12 weeks of pregnancy according to the guidelines. Fetal surveillance by serial ultrasound monitoring for risk of IUGR and antenatal fetal surveillance at a closer level. Treatment will be by folic acid preparations, antibiotics if there's infection, blood transfusion used in some cases, not always, analgesics in pain crisis, erythropoietin in pregnancy we do not use, but of course you can use hemotransfusions to keep the hemoglobin above 8, intravenous dehydration whenever they have dehydration like vomiting or high temperature or any painful crisis, you can hydrate them with adequate crystalloids. Of course, immunization as usual continue. Hydroxyurea has been used in the management of sickle cell anemia when in non-pregnant individuals, and studies have shown that they can be continued in pregnancy, but few studies say do stop the hydroxyurea once the woman is pregnant. So for the painful episodes, you have to provide adequate analgesia, but do not use NSAIDs. You can use acetaminophen or the plain paracetamol. In severe pains, you could also advise epidural analgesia, adequate hydration, and blood transfusion to reduce the concentration of the sickle cell hemoglobin so that the vaso-occlusive tendency will reduce. There are a lot of non-pharmacological strategies like behavioral strategies, cognitive behavioral therapy, acupuncture, psychotherapy, which have mixed data and mixed results in the data which is available. So what are the indications for blood transfusion? Acute complications in pregnancy like stroke, acute chest syndrome, acute anemia, acute reticulocytopenia, or any infections. Preparation for surgery if she is anemic and you feel it would improve the outcome if you maintain her hemoglobin above 8. Prophylactic transfusion again if you are suspecting any sort of painful crisis in any infection or dehydration. And now coming to hydroxyurea, as I already told you, non-pregnant, it is used to increase the fetal hemoglobin, but hydroxyurea should be stopped at least 3 to 6 months before pregnancy. That was the 2014 guidelines. But the recent guidelines say hydroxyurea in animals showed teratogenic effects. However, in humans, it showed no teratogenic effects. Patients with mild sickle cell anemia stop hydroxyurea. But if the patient has frequent or severe vaso-occlusive complications, please continue hydroxyurea in pregnancy. So explain the risk of using hydroxyurea to the pregnant mother, and the alternate for hydroxyurea would be frequent blood transfusion, and the blood transfusion, as I told you, will reduce the sickle cell hemoglobin. You can give folic acid supplementation dose 5 milligrams, start 3 months before pregnancy, continue 3 months after pregnancy. The other medications you need to stop if they are on ACE inhibitors, angiotensin receptor inhibitors, and hydroxyurea, you need to stop. Penicillin prophylaxis is advised for those women with sickle cell anemia. Thromboprophylaxis is also advised with aspirin and heparin. Then indications for prophylactic transfusion is sickle cell disease anemia with any other recurrent or a current complication in this present pregnancy with comorbidities, sickle cell anemia with nephropathy. So the time for a prophylactic transfusion will be in the 3rd trimester, so you have a better outcome. Labor management is going to be the obstetric indications only, so go for a vaginal delivery. Cesarean section is only reserved for obstetrical reasons. Timing 37 to 39 weeks. But in labor, try to keep them in the propped up position. She will require oxygen inhalation to prevent hypoxia. You have to hydrate her adequately, give her antibiotic prophylaxis, and also maintain her SPO levels. And it has to be under a lot of precautions, and the nurse and attendant should be looking out for signs of hypoxia, signs of acute chest syndrome, signs of any neurological or cardiac catastrophe. They should be kept warm. And if you are doing a cesarean, you can do it under regional anesthesia, and you can give a blood transfusion before cesarean so that her hemoglobin is at 8. Postpartum sickle cell disease, please continue the thromboprophylaxis 6 weeks postpartum, because many of them will have vaso-occlusive symptoms during the episodes during the postpartum. See that they are not dehydrated. You can, if they're undergoing cesarean, you can use pneumatic compression stockings. But of course, if the sickle cell trait is there, there is a very little risk of thromboembolism. So routine thromboembolism is not recommended. And the neonatal screening for sickle cell and thalassemia would be test the newborn for hemoglobinopathies, collect the cord blood. If the newborn does not have a hemoglobinopathy, try to harvest the stem cells if the facility is available. So when they're screening, you always take the baby's blood for screen and screen them for CBC, HB, and also do the hemoglobinopathy by the HbA1c. Contraception, oral contraceptives are contraindicated because estrogen increases the thromboembolic episodes. Progesterone only contraceptives are safe. The LNG IUCD would be the best choice. Do not use copper IUCD because there could be increased blood loss because of heavy menstrual bleeding. DMPA can be used. It decreases the sickling episodes, but there is a slight increase of venous thromboembolism. So the LNG IUS would be the best choice. So public health concern would be if left untreated, 20% of sickle cell disease children die by the age of 2. And by the ICMR survey, say 30% of the diseased children are among the tribal community and they die before they reach adulthood. And even if they survive, there's a lifetime risk of disease. And being genetic in nature, the numbers are bound to raise if suitable interventions are not made. So what are the interventions we need to make? Large-scale screening, counseling, awareness, and capacity building. And a move in this would be the budget 2023, which said India vows to eliminate sickle cell disease by 2047. So this was the marriage counseling card which is being used in Maharashtra. So before they get married, they have these cards which are marked white and half and yellow. So the one is the sickle cell trait, this is normal hemoglobin, and the sickle cell disease card. So this card is given to all those for screen, and before they get married, their counsel says try to find out on which card you have and try to get married with either a normal person or somebody who's carrying just having a trait. Two homozygous people should not get married, and even two heterozygous should not get married. The screening approach, as I already told you, adolescent screening is advised. Mass screening is not feasible, but however, we can do antenatal screening and husband screening, and newborn screening can be, so that we can follow the treatment. So this is definitely a massive exercise, and so far the government of India has been taking it up in a big way, and let us all join hands in trying to maintain a registry of sickle cell disease and help eliminate this disease. So this is what I've told you. And now coming to thalassemias, I think Megha, we already have another talk on thalassemia. So I don't think I should be talking on thalassemias, because we have a panel on thalassemia and we also have another talk on thalassemia. Is it fine, Megha?
Ma'am, I think a few points.
Okay, fine. So thalassemias, as I already told you, it is, of course, there is the global chain synthesis is altered. It is again a heterozygous genetic defect. We have two types, alpha thalassemia, beta thalassemia, and in beta thalassemia also we have the major and the minor traits. And as I told you, alpha thalassemia, there's a defect in the alpha chain. There's a quantitative defect, that is the percentage of alpha chains are reduced, and in beta it is the quantitative effect of the defect in the beta chains, autosomal recessive. And alpha thalassemia, again we have HbA1, HbA2 because of the genetic mutations in the short arm of the chromosome 6. And it is more, the beta thalassemia is more common than alpha thalassemia. There is a regional variation more common in Mediterranean areas. In India, the Punjabis, the Sindhis, and Western Indians, Saurashtrians have a higher incidence of thalassemia. And even in Karnataka, we have a higher incidence of thalassemias. So as I already told you, it is coded by beta chain by a single gene on short arm of chromosome 11, while the other alpha chain is coded by the short arm of 6. Chromosome 6. So normal situation, the mother will be B, the father will be there. Definitely the fetus is going to be B if they are thalassemia carriers. But however, if the mother is negative and father is negative, the positive, the baby will be a minor trait. But if both are negative, then they do not have the beta chain, then they will have the major anemia. So this is the genetic transformation again. If parents are healthy, there is no problem. If one parent is unaffected, the carrier possibility is only 25%. But if both the parents are carriers, there is a 25% chance of an unaffected child, 50% chance of children being carriers, and 25% of having a thalassemic child. So, and how do we identify this thalassemic child? I will tell you. That is what is most important. How do we identify by the HPLC? So, in the beta thalassemia trait, of course, they're going to be anemic. They will have low indices, low MCV, low MCH, and a normal MCHC. And when we do the hemoglobin electrophoresis, you will see that the alpha chains and beta chains are quantitatively reduced. In beta thalassemia minor, they're just carrying the trait. Management in pregnancy is going to be just like a normal pregnancy. Frequent hemoglobin testing, iron and folic acid supplements in usual dose. Parenteral iron should be avoided because of iron overload. If they are not responding, you can give intramuscular folic acid, blood transfusions if necessary during the close to delivery. So alpha thalassemia, again, you can have the trait as well as the alpha thalassemia major. And this alpha thalassemia major, most of them do not even reach adulthood. So that is, I'm not going to talk about that. And this beta thalassemia is what we see more common. And in beta thalassemia major, there's a homozygous inheritance from both the parents. They have this typical phases in thalassemic major, diagnosed in pediatric age because of repeated episodes of anemia. And the treatment is either blood transfusion or stem cell bone marrow transfusion. So what causes the pathophysiology is these beta chains form insoluble inclusions. interfere with cell division, damage cell membrane, they perturb the internal ionic activity, there is a reduced RBC deformability, leading to death of erythroid cells, ineffective erythropoiesis, leading to bone changes, splenomegaly, multi-organ disease, and anemia. So they require repeated blood transfusion. So I will not go into all these details because I'm sure they're going to talk about this later on. So the first antenatal visit, try to get a hemoglobin electrophoresis and a full blood examination, including the peripheral smear and the ferritin levels. If the MCV is less than 80, see, this MCV is something that you have to be very, very cautious about. If the MCV is less than 80 and MCHE is less than 27 and ferritin levels are low, you could take it as iron deficiency. But if the MC is 80 and the ferritin levels are high, so this is a very good indicator. MCV is less than 80, but ferritin levels are high. Please think of thalassemia or hemoglobinopathies and try to get a hemoglobin electrophoresis and confirm the diagnosis. Along with that, you will look into the other risk factors when you want to screen her for thalassemia. Is she from an ethnic population? Is there a past history of anemia? Is there a past history of not responding to iron therapy? These are all pointers towards whom we could screen. So the normal low MCV, normal MCV and high. If it is high MCV, always think of folic and B12 deficiency. If it is low MCV, ferritin levels are high, please think of hemoglobinopathies. If there is hemolysis, if there is bleeding, anemia, retic counts are very normal or low, please think of, if retic counts are high, think of hemoglobinopathy. If retic counts are low, think of infections and impaired RBC production. So the clinical presentation again will be pallor, jaundice, repeated blood transfusion, the chipmunk faces, splenomegaly, and the MCV is decreased, hemoglobin level is decreased, ferritin levels are high, retic count is going to be high. This is the standard typical chipmunk faces you would identify children who are suffering from from thalassemia major. So suspect thalassemia whenever there is refractory anemia, microcytic hypochromic with increased serum iron, and try to do the screening test as the HB electrophoresis is what we would recommend. So complete blood count, peripheral smear, and of course the other examinations. And when you do the blood indices, I already told you the MCH in beta thalassemia is going to be decreased, MCHE is going to be decreased, red cell will be normal, however the hemoglobin profile will give you the correct indices. So I'm just skipping through. So the gold standard will be the high performance liquid chromatography test for prevention and diagnosis, because it is reproducible, it is simple, and it is easily available. It can identify not only thalassemia, it can also identify your other hemoglobinopathies also. So in thalassemia and pregnancy, they may present to you in infertility. So look into that. Preconceptionally, they should conceive only if their cardiac function is normal. Main cause of death in beta thalassemia major is congestive cardiac failure due to iron load. So if patient attains pregnancy, usually the pregnancy outcome is normal. Partner testing is mandatory. Prenatal testing of the baby by chorionebular sampling or amniocentesis is essential, because if the baby is thalassemia major, you can do the counseling and give them the option of a medical termination of pregnancy. And the Thalassemia Society of India provides all these managements free of cost to those women if we refer them to that setup. So in minor patient, there is no difficulty. They can carry on as a normal pregnancy and just do the partner testing to find out if at all he is a heterozygous or a homozygous carrier. If they are minor alpha thalassemia, provide folate supplementation, screen the partner and monitor hemoglobin and transfusion of anemia as usual. Routine antenatal care and oral iron, IV iron is contraindicated. So I've already told you this, monitor. And thalassemia, as I told you, Bart's is a very difficult situation. These babies which are born with Bart's syndrome will usually have hydrops, which is incompatible with life. So whenever somebody presents with hydrops, not only he RH incompatibility, we'll have to also think about hydrops due to thalassemia. And in that person having a hydrop fetus, the intranatal and the postnatal complications also may be magnified because of the larger size of the baby. So management of beta thalassemia is to maintain hemoglobin at 10 grams per blood transfusion. Do not give oral and parenteral iron. Vitamin C is also contraindicated because it leads to increased absorption of iron. In case there is an iron load, you will have to give desferoxamine to chelate the excess iron to prevent the complications of iron overload and supplement folic acid. Try to maintain the ferritin levels at 1000 to 2000 milligrams. And the labor management will be as per any other individual unless cesarean is done for an obstetrical reason. Contraception, again, there is increased coagulopathy, so oral contraceptives are to be avoided. Labor, as I told you, try to keep cross-matched blood. Postnatally, follow up the women and try to screen the baby. Chorion Miller sampling in the antenatal period, amniocentesis at 16 to 18 weeks, and if there is thalassemia major, give them the option of a medical termination of pregnancy. So I'm just guessing that this is the approach to the pregnancy, which I have put it again because the CBC, MCV, MCH, and HPLC, I think this should be there in the screening of all our women in today's present scenario. And you all know that in most of the countries, this is already included in their protocol, and it is high time we also, most of the metros consultants are doing that. I think we also should give them this option. And if we can speak to the laboratories and tell them that we are going to do these tests in a larger profile, they will ready. I am trying to negotiate them to bring down the prices so that we can advise this test to all our pregnant mothers or even our adolescent girls who come to us with anemia for any other reason. Try to rule out hemoglobinopathies in them. So prevention is premarital screen is very, very important. A difficult situation in our country, but I think we need to start counseling about this. Second step is genetic counseling to those who are affected and tell them to take an informed decision. And the third step is prenatal diagnosis to detect any fetus which is affected in early gestation and give them the choice of termination of pregnancy. So the take-home message would be universal screening, prenatal test whenever indicated, public awareness about hemoglobinopathies and the availability of screening options, premarital screenings, chronic anemia, always think of hemoglobinopathies, and please follow the protocols for management. And in case you have patients with hemoglobinopathies, please do have a team approach, consult your perinatologist, consult your pediatrician, your hematologist, and manage as a team. Thank you very much for the patient hearing. I thank the KSOGA Perinatology Committee for giving me the opportunity, and I am sorry if I have overstepped my time. Thank you very much.
Thank you, ma'am, for that very, very informative talk on hemoglobinopathies in pregnancy. It was very exciting, I can say, covering up both the sickle cell and the thalassemia.
Yes, Bharti ma'am, it was a fantastic talk, especially for highlighting the very, very important points of premarital testing also, so that, the couple wouldn't end up having the thalassemia affected fetuses, and bringing in the awareness that in presence of anemia, which is uncorrected by the routine administration, we used to have a thalassemia ward in North India, PGI Chandigarh, where I did my internship. There used to be a ward dedicated for thalassemia. Such was the high prevalence of thalassemia, as you rightly pointed out, some geographical pockets which have higher incidence, and suddenly the couple would end up having a baby or a child. I had one such patient of infertility, conceived on treatment, and later on had a thalassemia baby, which was the mother knew that she was thalassemia minor, but she didn't reveal that she had so. Subsequently, we started testing for all the pregnant patients, as you have rightly pointed out, and definitely the labs are cooperating, and they have brought down the charges, and I think it goes a big way and a long way, that when the couple can do baby moon shower and all such kind of showers, they might as well get their blood testing done and save for their progeny and for the future generations. Thank you so much for bringing in such beautiful presentation and highlighting the valid important points, and also the initiative taken by the government to sensitize the patient and provide the free treatment and care, which I think all obstetricians should be aware of, that they can make avail of these services which are prevalent. And thank you very much, as usual, for your beautiful presentation.
And as is rightly said, see, women now are very open to getting the double marker. Initially, when we were doing the double marker, we were a little hesitant, will they pay, will they get it done? But now they are very readily getting it done. So similarly, I'm sure if we do the HP electrophoresis, they will definitely get it done because they want a healthy baby. And as you said, just 2 months back, there was one woman, she was a Muslim woman. Very rare to have thalassemia in that ethnic community. And she was not responding to oral iron and IV iron. Luckily, in pregnancy, she didn't have any problem. Then she had an IUGR baby delivered. Then first day postnatal, something struck me. I said, why is she not responding? Why is she again hemoglobin dropping to 7? And we got her hemoglobin electrophoresis and she was suffering from sickle cell trait. And then we have referred the baby, like the baby is not a carrier. So that happened. Routine
Stuck, ma'am. Your
is
voice
what
is
we
stuck.
need to take up. Over to you, Megha. Thank you.
Thank you very much, ma'am. It was very elaborative and very precise presentation, ma'am. Actually, our panel is going to highlight on how to read a hemogram and how to suspect hemoglobinopathies. If not possible to get HB electrophoresis, then in poor resource settings. So very interesting talk, ma'am. Thank you very much. Can we invite our next speaker? And
Yes, madam.
Thank
Yeah.
you.
Thank you, Bharati ma'am, for the talk, and thank you, Rajashri ma'am, for chairing the session. We are going to move on ahead with our second topic for today, Journey with Thalassemia, Guide from Conception to Birth. The speaker for this session is Dr. Shubha Vadigar. I'll be sharing the slides. Yes, so we have Dr. Shubha Vadigar. She's a hemato-oncologist from Narayan Hospital, Bengaluru. And for chairing the sessions, we have Dr. Shanta Durge. She's the chairman for Public Awareness Committee, KSOGA. And Dr. Suman Gaddi. She's the treasurer for KSOGA. I would like to briefly introduce our chairpersons, Dr. Shanta Durge. She is a nominated member to Karnataka State Supervisory Board, PCPNDT, Clinical Director and Chief Consultant at Durge Clinic and Fertility Center, Basava Kalyan. She is Korean Commendation, Siliguri, AICOG, 1997 for her original research work on female feticide. Distinguished Community Service Award at AICOG 2007, Kolkata. She has many poster awards at AICOGs and state conferences. She has also received the Godfrey Phillips Bravery Award, Orissa 2009. She has many state awards to her credit. She is a faculty at AICOG state conferences till today.
Ma'am, please be short.
It's very nice to read your CV, ma'am. You have so many achievements. Very nice, ma'am. Yeah, and she has written many novels on female feticide, and she's activist for Save the Girl Child and to protect girls' right movement since 26 years. Thank you, ma'am.
Thank you.
Our next speaker, chairperson, Dr. Suman Gaddi.
You already read my CV
yes,
earlier, I believe. I think you can skip.
Yes,
Thank
I would
you.
just invite Dr. Shanta Durge ma'am to invite our speaker for the session.
So I have to introduce her. I'm supposed to introduce her.
Yes, madam. Yes.
So Dr. Shobha Vadigar, she is the senior consultant pediatric hemato-oncology and BMT in Majumdar Shah Medical Center. MBBS in KMC Hubli, followed by MD Pediatric in BMC Bangalore, and fellowship in hemato-oncology in Narayana Health Bangalore. Have more than 20 publications in national and international journals. Special interest in bone marrow transplantation and have expertise in allogenic transplantation, matched and mismatched with 2,000 and more transplant in MSME Bangalore. Drug and Safety Board member. Also have special interest in leukemia, soft tissue malignancies, and osteo and Ewing sarcoma. Have won Young Icon Award for presentation on pulmonary embolism in choriocarcinoma. Also passed in distinction in medical law and ethics, PGDMLE under National Law University Bangalore, and hospital management certification in Bangalore, and executive board member South Zone in Pediatric Hematology, IAP Society, South Zone, India. So this is the introduction of Dr. Shobha Vadigar, who is a very distinguished speaker, and she will talk on the subject from the conception, journey from the conception onwards, conception to birth. Over to Dr. Shobha Vadigar.
Thank you, Dr. Shanta Durge. That was a very nice introduction. Thank you very much. And I thank.
You have got so many accolades with you, yeah?
Sorry?
So, you have got so many accolades with you.
Thank you, madam. I also thank Dr. Megha for inviting me for this session, and I'm very happy to interact with obstetricians. It's mostly with the pediatricians that I interact, and this is something new and exciting for me. I'll be talking on this topic, basically going to focus on what we have to do during, from conception to birth. Childhood diagnosis will be very brief. So already Dr. Bharti spoke about what is thalassemia. So we already know that it is a hemoglobinopathy, and it is the most commonest hemoglobinopathy worldwide and in India also. And we diagnose it with HPLC, so I'll not go into detail with this. And we also need a DNA analysis whenever possible, because this is going to help us to know what is the kind of mutation, to prognosticate about the iron overload status, and also to do prenatal diagnosis. So what is the burden of thalassemia in India? Why do we need a World Thalassemia Day every year? In India, we have around 1 lakh patients with beta thalassemia syndrome, and around 10,000 to 12,000 children are born with thalassemia every year, just in our country alone. And if you look at it every year, almost 2 million units of packed red cells are required for the transfusion of these patients in our country. And if you take into account the admission charges, the blood cell charges, if they're going to a private hospital, and even to the government hospital, the transport charges, waiting, and loss of pay during that time, if you consider everything, almost the cost is around 13,000 rupees per transfusion for the family. If the patient goes for a bone marrow transplantation, the cure, which is a curative treatment, the cost varies anywhere between 15 lakhs to 35 lakhs minimum rupees, depending on the type of donor that is used for bone marrow transplantation. This is just what can be accounted in numbers. But there are so many other problems that you cannot account in numbers, like loss of work, other family members who are getting compromised in their life or being neglected because all the attention is on the thalassemia child, the emotional burden the family and the patient has to go through, and the kind of struggle the child and the family has to go through to get blood month after month, year after year, lifelong, to procure the medicines, iron chelation, and the poor quality of life and the complications that they have to deal with. These are something that we cannot quantify. So this is the burden of thalassemia. Now, why is it called a thalassemia syndrome? Because thalassemia can present in varied phenotypes. It can either be totally asymptomatic, or thalassemia can present with occasional blood. The patient may require just occasional blood transfusions during intercurrent illness like common cold or some other infection, or they may require transfusion but not very regular, maybe once in 2 months, once in 6 months. Or the extreme presentation is regular lifelong blood transfusions along with iron chelation. So based on this, now the new classification is thalassemia, which is non-transfusion dependent thalassemia, and thalassemia that is transfusion dependent. So we do know there is beta thalassemia, alpha thalassemia, E beta thalassemia, but all of them are classified broadly into non-transfusion dependent and transfusion dependent thalassemia. So alpha thalassemia trait, beta thalassemia minor, these are all asymptomatic patients, and patients with mild HB-E beta thalassemia, HB-C beta thalassemia, and deletional HB-H thalassemia, and moderate HB-E beta thalassemia are non-transfusion dependent thalassemia. Whereas another type of HB-H thalassemia, which is non-deletional HB-H thalassemia and beta thalassemia major, and again HB-E beta thalassemia, which is of a severe phenotype, are considered as transfusion dependent thalassemia. So finally, our management will be based on whether they are transfusion dependent or not transfusion dependent. So how do you diagnose? Proper medical history is required to know what is the symptoms, that is breathlessness or pallor, jaundice, all these histories required, abdomen distension because of hepatosplenomegaly. And once the symptom is there, you do the basic complete blood count and look at the hemoglobin, which tells that there is anemia. So anything less than 10 gram per deciliter is considered as anemia. And low MCV, low MCH, Dr. Bharati had already stressed on this. Look at the peripheral smear, which shows microcytosis. Target cells are very, very important. And if it is HBH, there are inclusion bodies also. If the ferritin is more, then it again hints that it is thalassemia. More important is reticulocyte count. I have not mentioned one more thing here, which will come in the next table, that is red cell distribution width. Red cell distribution width is extremely important to differentiate between iron deficiency anemia and thalassemia, because both in iron deficiency as well as in thalassemia, you have anemia, low MCV and low MCH. So finally, when you're suspecting thalassemia, we diagnose it with HB electrophoresis or HPLC. And here you look at mainly HbA2 and HbF. Whenever HbA2 is more than 4% with low HbF values or normal HbF values, it is beta thalassemia trait. If it is less than 4% and HbF is also less than 1%, it is alpha thalassemia trait and related problems like alpha with alpha thalassemia. If HbA2 is more or equal to 4% and HbF is also high, that is 5 to 50%, it is thalassemia intermedia, and these patients may or may not be transfusion dependent. So they can either be non-transfusion dependent or they can be transfusion dependent. Just because the HB electrophoresis is showing thalassemia intermedia, we should not go by the diagnosis of thalassemia intermedia. Clinically, they may be thalassemia major itself. Then HbH will have HbH component also in addition to HbA2. Then there are various other variants. Among these, for us HB, I would like to stress on HBE. HBE will have a similar picture to thalassemia intermedia in HPLC, except that HbA2 will be extremely high. It will be more than 20%. So if you have a very high HbA2, then it is because of HBE thalassemia, where the HBE curve overlaps with the HbA2 and makes it look very big. So this is a brief thing. In all the patients, it is always better to do a DNA analysis, because DNA not only tells what gene is affected, there are many mutations that will also help us tell how bad the iron overload will be and how difficult it is to control. So this is a table to show the difference between iron deficiency and thalassemia. In both of them, there is anemia. In both, there is low MCV. But RBC count is slightly higher in thalassemia, but it is normal in iron deficiency. It is high because the bone marrow tries to produce more RBCs. Reticulocyte count is high again in thalassemia. Ferritin is increased, whereas here ferritin may be low. But ferritin is kind of a reactive phase chemical, and therefore it can be falsely increased in iron deficiency anemia also. What is very important is transferrin saturation. In iron deficiency anemia, transferrin saturation is always low and is less than 10%. RDW is the red cell distribution width. In iron deficiency anemia, the RDW is high. This will kind of give us a very big clue whenever you see a CBC to tell that this is not iron deficiency anemia if the RDW is normal or low. There are other things like Menza's index and so many other indices, which as a hematologist, I have not used, but as a pediatrician, they still use these indices to differentiate between iron deficiency and thalassemia. Peripheral smear, of course, shows a lot of similarity between the two, but basophilic stippling is more common in thalassemia. And HbA2, I already stressed, it is high or normal depending on the type of thalassemia that we are dealing with. So this is a typical look that a thalassemia child has, and our aim as pediatricians is to make sure that no thalassemia child develops this kind of look. If a child has this look, that means they are totally mismanaged. The blood transfusion has been totally inadequate. Iron chelation has been totally inadequate. A properly transfused thalassemia child, a properly chelated thalassemia child looks absolutely normal, and they can lead a normal life. So this is what we call a class 3 thalassemia, which is a very high risk thalassemia, which is poorly managed. So to understand this better, we have what is called Pesaro classification. Here we classify it into 3 parts: class 1, class 2, and class 3. Class 1 patients are all thalassemia major patients who do not have hepatomegaly, who do not have any iron overload in the form of portal fibrosis in liver biopsy, which we don't do routinely, but this is a basic classification. And they are on regular, adequate, weight appropriate iron chelation. Class 2 patients are those who have 2 of these factors, but one is normal, 1 or 2 of these factors. Class 3 patients are those who have all of these. They have hepatomegaly, their iron overload is very severe, therefore they have portal fibrosis, and their chelation is very poor, so they have they have irregular chelation. So if we diagnose them early, and if we transfuse them adequately, then they're always in class 1 or maximum class 2 at whatever age you see. If they go to class 3, the blame is on us pediatricians who are not dealing with them properly. So iron load can cause a lot of problems, both in transfusion-dependent thalassemia as well as in non-transfusion-dependent thalassemia. In non-transfusion-dependent thalassemia, the main reason for iron load is increased intestinal absorption of iron. The body has a mechanism to absorb iron. It is called a hepcidin pathway. Through this pathway, iron gets absorbed whenever it detects anemia, irrespective of what the cause of anemia is. And if the anemia is associated with ineffective erythropoiesis, this hepcidin pathway gets activated and starts absorbing iron more and more from the gut. Therefore, even though they are not transfused repeatedly, non-transfusion dependent thalassemia can present with iron overload. So what are the symptoms that they can have with iron overload? There will be a lot of hormonal disturbances like pituitary dysfunction, hypothyroidism, hypoparathyroidism. It can affect the organs, mainly the cardiac, causing arrhythmias, heart failure, liver hepatomegaly, liver fibrosis. It can cause diabetes, hypogonadism, poor puberty, infertility, bone fragility, bone diseases can happen. They are more prone for infection. And in non-transfusion dependent thalassemia, it may not be so dramatic, but there may be silent strokes, hypothyroidism, pulmonary hypertension may be seen. And unless you do an echo, we might miss it. There may be liver fibrosis, proteinuria, hypogonadism, venous thrombosis, leg ulcers are very common, and bone disease is also seen. In non-transfusion dependent thalassemia, this iron overload symptoms comes above second decade. So we rarely see this in children. So how do we treat? In very briefly, blood transfusion, iron chelation is still the hallmark of treatment, and it has to start from the day we have diagnosed thalassemia. The most important thing is to maintain the pre-transfusion HB, not the post. Before the transfusion, the HB has to be 10. And if it is below 9, the child has to be transfused 2 days or 3 days, depending on how low the hemoglobin is. The aim is to maintain at least 9 to 10 gram per deciliter of hemoglobin throughout their life. And in addition, give iron chelation. If the ferritin is more than 1000 nanogram per deciliter, you start iron chelation in case of thalassemia major. And if it is more than 800 nanogram per deciliter, in case of non-transfusion dependent thalassemia, we start iron chelation. In addition to this, there are newer treatments like luspatercept, hydroxyurea, which increases the HbF level. Hydroxyurea increases the HbF level. There are other drugs like 5-azacitidine, decitabine also, which increases the HbF level. And this kind of reduces the imbalance between beta and globin chain. And therefore, the hemolysis is reduced and the frequency of transfusion is reduced. There is a newer drug called luspatercept, which also reduces the frequency of thalassemia, blood transfusion in thalassemia major. And this is mainly now FDA recommended for 12 years and above. And so we have already started using this in adult. And instead of the patient getting it in monthly transfusion, they're able to get the transfusion once in 3 months, once in 4 months, and slowly the frequency reduces. However, it has to be taken throughout the life to maintain this kind of lifestyle. And it is really helpful because the patients need not go hunting for blood every month. Then there is allogenic bone marrow transplantation. As of now, this is the only treatment which can cure the patient of thalassemia major. And this has to be counseled. The patient has to, the parents have to be counseled about transplantation the moment the diagnosis is made, because it is very expensive, minimum 10 to 15 lakhs it starts with, and it's not easy for the parents to arrange this money overnight. So if you diagnose a patient at around 6 months of age and you tell them this is a curative treatment, they'll be mentally prepared and they'll be emotionally prepared, and they will start getting financially prepared. And when the child is between above 1.5 years, the child is fit for bone marrow transplantation. It's always better to transplant before 7 years of age, but even after 7 years of age, we can transplant the child if the liver, if the iron overload has not caused any complications and the growth and hormonal status and cardiac status is normal. We have done transplantation for 3 patients who are adults. One of them was 26-year-old, successfully transplanted and is now an engineer and leading a normal life. The gene therapy is a newer treatment where we use lentivirus to cause genetic engineering. And the difference between allogenic transplant and gene therapy is in allogenic transplant, you need a donor to donate stem cells, whereas in gene therapy, the patient's own stem cells is genetically engineered, and similar to allogenic transplant, myeloablative chemotherapy is given, and then the patient's own genetically engineered stem cells is infused, and these cells starts growing in the body of the patient and finally produce normal RBCs, and they are free of thalassemia. The problem with gene therapy is this effect of genetically engineered stem cells to sustain in the body is still not happening. Within 7 months, 1 year, it fails and they go back to thalassemia. And in addition, they are having other unwanted complications, including secondary malignancy. That is the reason right now gene therapy is still not recommended. Whereas allogenic stem cell transplantation has got given very good cure rates up to 95% success in patients who are well maintained. So the burden of thalassemia, like I already said, financial burden, loss of work, other family members are affected. All these are there. And that is why we need to know all this about thalassemia. Now, there were studies done to know what was the awareness about thalassemia. And it has shown that in many centers, especially cities, including Bangalore, the awareness about thalassemia among the pregnant women was very, very poor. It was at the rate of 0.2 to 5% in Bangalore, Mumbai, metropolitan cities. And in Kolkata, it was slightly better because there E-beta thalassemia is extremely prevalent. A KAP study about beta thalassemia showed that this was in South India. Nobody knew about thalassemia, and many misconceptions of thalassemia was there, like thalassemia is because of some kind of a sin committed by the parents. And those people who knew about thalassemia, more than 50% of them were not even willing for premarital screening for beta thalassemia. To educate the people, general public about thalassemia, various national programs and state programs have been introduced in different parts of the country, like National Health Portal of Ministry, Jai Vignan program. In West Bengal, there is a thalassemia control program. Gujarat state also has it. In Maharashtra, there is a program. There's a Project Rainbow in Punjab, which also includes sickle thing, like Dr. Bharati already explained. And in Bangalore, some antenatal screening studies were done. And currently, the latest is Rashtriya Bal Swasthya Karyakram and Thalassemia Bal Seva Yojana. These two programs are doing extremely well. This is national-wide, it is not statewide, and they are helping educate the thalassemia about thalassemia, prevention, screening, and treatment, and appropriate chelation and transfusion. All this is being taken care of, and it is slowly improving the awareness about thalassemia. Thalassemia Bal Seva Yojana is also giving funds through Coal India program, about 10 lakh rupees for bone marrow transplantation for those who have matched sibling donor. And our center with this has been able to do more than 200 transplants using Coal India program. So what is the aim of these programs? One is efficient treatment of thalassemia major and non-transfusion dependent thalassemia, and to prevent further births of children with thalassemia major, therefore to reduce the incidence of thalassemia. So this is achieved by screening traits. First step to screen the trait is thalassemia trait is to do the complete blood count. And if we see low MCV, low MCH, normal red cell distribution width, and high RBC count, if these 4 factors are there, then do HPLC and rule out thalassemia major. So every single man and woman has to undergo this, especially if they are planning to have a baby. Then how to differentiate iron deficiency anemia is extremely important, because it is assumed that whenever there is anemia, it is iron deficiency anemia. So it is important to differentiate and not miss thalassemia trait for iron deficiency anemia. So we go by RBC indices, and if these parameters, that is microcytic hypochromic anemia is there, RBC count is normal, RDW is normal. If HbA2 is less than 3.5% and HbF is normal, that means the person is normal, is not a trait, is not a disease. If there is same parameters, low MCV, low MCH, RBC count is high, RDW is normal, and HbA2 is more than 3.5%, then they are beta thalassemia trait. Watch out for these people, because they are totally asymptomatic, and these are the ones who will give rise to thalassemia major patients. So these are the ones have to be screened and picked and educated. thalassemia, MCV low, MCH low, RBC count is high, RDW is normal, HbA2 is low and HbF is normal. They can be silent beta thalassemia, and the only way to diagnose silent beta thalassemia is through genetic analysis. That is why education is extremely important. And if there is a family where you do not find any trait in HPLC, but the baby is born thalassemia major, it is because the parents were silent beta thalassemia carriers. They can also be alpha thalassemia traits. If the MCV, MCH is low, RBC count is normal or low, and RDW is high, again, HbA2 is low and HbF is normal. It is iron deficiency anemia. And in HPLC, if you see other variants like S, E, and D, then it is other types of thalassemia. So this is a basic way of diagnosing, and most important for all the obstetricians is to differentiate between iron deficiency anemia and thalassemia trait, and to not just go by HB, see the MCV, MCH also, see the RBC count. We tend to forget RBC count and RDW. If RBC count is above normal, if RDW is more than 13, it should ring bells to you that it is not iron deficiency anemia. Okay, this I already told. One thing I would like to stress is HbA2 can be borderline or normal in certain conditions, but this is generally not a problem in routine testing. So all these, everybody has to undergo genetic counseling, and the aim of genetic counseling is to eliminate these irrational fear and stigmatization regarding thalassemia, to help them come to terms with the thalassemia situation and the consequences of the disorder if they have a child with thalassemia. It also helps to help them to take the right decision for future reproductive choices, so that the next child is not born with thalassemia major, thalassemia trait or non-transfusion dependent thalassemia is acceptable, but not thalassemia major. It also, genetic counseling also helps them to understand the clinical presentation, complications, and how to prevent and treat the disorder. So who are all the candidates who are eligible or who should be counseled? Ideally, everybody. You, me, our children, everybody's children, all the adults in the world have to undergo counseling about all hemoglobinopathies, particularly thalassemia and sickle, because it is quite common in the community. Prenatal test that all should ideally undergo is complete blood count, peripheral smear, reticulocyte count, iron profile, and HPLC. In those people who are showing features of thalassemia trait, in them we need to do prenatal fetal testing. So what we do, how do we trait? How do we screen the trait? First, you do CBC, and we find all these features that I already described. Then you look at the peripheral smear, if it is showing microcytic hypochromic and target cells. Then do HPLC, and if they are trait, this is about the lady, the mother. If they are traits, then you do the HPLC of husband. This is not an ideal situation. Ideally, you should do both the wife and the husband. But if she's already pregnant, then this is the order. Then you do the HPLC of the husband. And if husband is also a trait, then you have to offer prenatal tests. If the lady is not pregnant, offer them PIGD, that is pre-implantation genetic diagnosis, which will be an ideal situation. So in your clinic, it may or may not be possible with your busy schedule. So it is always better to have a nurse or another person to do all this counseling, spend time with the parents and with the couple, and help them understand the importance of this. So what happens about for fertility in those who are having thalassemia? Thalassemia trait and thalassemia intermedia, which is non-transfusion dependent, generally have intact fertility, so they can go ahead without any assistance with the pregnancy. But thalassemia major, their fertility depends on how well they are transfused and how well they are chelated. If they are well transfused and if they are well chelated, they do have their fertility is still intact and they can become pregnant, but they may need assistance because of certain other complications, because of iron load especially. So what are the things that you could cause problem in these ladies if they are having thalassemia intermedia or thalassemia major, whether it is non-transfusion dependent or thalassemia major? What are the problems? The main thing is hypogonadotropic hypogonadism, which is seen in almost all these people. And this can result in pubertal failure, sexual dysfunction, infertility, depending on how severe this hormonal disturbances is. Antirepituitary gland can be affected because this has a transferrin receptor and absorbs iron much more than any other gland. Ovaries and testes undergo maturation defect, embryo development can be affected. There can be a lot of miscarriages. Other endocrinopathies are also seen, diabetes, hypothyroidism, but all these will happen in those who are poorly chelated. In case they do get pregnant, especially the non-transfusion dependent thalassemia, we have to watch out for these problems. They are prone to have cardiac dysfunction because there can be increased cardiac load, chronic hypoxia and myocardial iron deposition, and gestational hypertension is very common if they have been not adequately transfused before conception. And because of the iron chelators, hydroxyurea, there is potential teratogenicity, and they have high risk of thromboembolism, especially in the thalassemia intermedia patients, because it is a hypercoagulant state. In thalassemia major, if they have undergone splenectomy or if they have autoimmune antibodies, they have a high risk of thrombosis. And during pregnancy, they may require transfusions. Diabetes, hypothyroidism may be there also because of iron overload. And there's a high risk of miscarriage, IUGR, premature labor, and fetal death. It sounds very, very odd when I say thalassemia major and thalassemia intermediate going into pregnancy, but we have seen this in really well chelated and transfused patient, although it is extremely rare in our country. In other countries, this is present, and we are hoping that it will come to our country, which means we are managing the thalassemia patients really well. What are the different options for fertility? One is it depends on the partner's carrier status, and second, how bad is the damage in the HPG axis. So prenatal diagnosis, I'll skip this because it came, this was by mistake. All right. So the fertility options, if both are homozygous for beta thalassemia, then it is better to use a donor gamete, especially a sperm, to for the conception. I will not go into details. I'm a pediatrician, so I don't know much about this, but it is not advisable to get pregnant if they're homozygous, both the parents. If the partners are heterozygous, they are either non-transfusion dependent or they are trait. In that case, there are two options. One, if they do conceive, then offer prenatal diagnosis through CVS or amniocentesis. But this is only if they are ready for abortion. If they are not ready for abortion, we have seen families where one child is thalassemia major and the mother comes with being pregnant. And when we offer them prenatal diagnosis, they do go for prenatal testing. When the report is ready, they refuse abortion. Especially certain communities don't like abortion and they will go ahead with the pregnancy. So prenatal testing of the fetus is really not worth if their religious sentiments or whatever it is, social sentiments do not allow abortion. In such patients, you can counsel pre-implantation genetic diagnosis, where diagnosis can be made prior to conception. Those who have severe iron overload or organ damage, they should not become pregnant because there is high risk of morbidity and mortality. And for these patients, adoption is the best way and, in fact, the only way. In fact, they may not even become pregnant. If you, by miracle, see anybody getting pregnant with this kind of poorly managed thalassemia, then they are not fit for pregnancy. So ovulation induction and sperm induction are the ways by which pregnancy can be induced, because it is the ovum and the sperm can still be intact. It is the HP axis that is affected in thalassemia patients. So endocrine assessment before you plan conception. This is especially in non-transfusion dependent thalassemia because they look okay otherwise. So, monitor them, test them for diabetes mellitus, thyroid function, osteoporosis and deformity is very, very important. Their bone can be really weak. They may have pelvic deformities because of the poor bone formation. And this has to be assessed if they are planning pregnancy. High risk of infections are there because of iron overload, which disturbs immune system, and even an occasional blood transfusion in non-transfusion dependent thalassemia could have exposed them to various viruses like HCV, HIV, HBV, CMV, and parvovirus. So test them before planning pregnancy and then treat them before conception. Splenectomy if they have already undergone splenectomy, continue penicillin prophylaxis and counsel them about any infection because they are highly prone for infection with capsulated organism. They should have got vaccinated for all these capsulated organisms. So pre-pregnancy counseling is extremely important. One, to look for eligibility. Are they eligible, first of all, to go through this pregnancy? And for the physicians to check the medications, to stop the medications which they are already on, to start certain medications which they are not on, and also to understand the risk associated with induced fertility and pregnancy. So the test that has to be done is CBC to look for the requirement of transfusion. This is in those people who are already known to be traits or thalassemia intermedia. Look at the cardiac function. Here I would stress on grade 2 T2 star MRI, which is a non-invasive type of detecting iron overload in the cardiac and liver. This we do routinely in our hospital, and we have found many patients who have not so high ferritin levels, but have high iron overload in liver and cardiac. And we have also seen many patients who have conceived. I have one patient who was thalassemia intermedia and who has conceived and who has a normal child because of the prenatal and all that. So we need to be aware of these tests that they have to undergo. ECG, liver function test, cholecystectomy has to be done because they're very highly prone for cholecystitis because of their lower immunity and sometimes gallstones being present in thalassemia intermedia. Like I said, screen for all the viruses and establish bone health before planning pregnancy. So there are certain drugs which should be stopped. The main thing is iron chelation. If they are on iron chelation before pregnancy, this iron chelation has to be stopped. And if you have planned conception, but they're still not conceived, then continue desferrioxamine, which is a IV or subcutaneous iron chelation. Once they conceive, stop it. And from after the first trimester, start the desferrioxamine. It is still in animals, it is proven that IV iron chelation can cause teratogenicity, but humans, it is not proven. But since it is still not, the studies are still on, it's better to stop this. All other drugs, oral iron chelators, are all teratogenic and therefore they have to be stopped. Some patients may be on interferon, hydroxyurea, hypoglycemic agents, bisphosphonates to improve the bone health, AC inhibitors. These are all very common in non-transfusion dependent thalassemia. All these have to be stopped at least 6 months prior to pregnancy. Counsel about the mode of delivery, and Dr. Bharti has already talked about this in detail. Once the mother is pregnant, then if they are thalassemia major, maintain the transfusion above 10 gram per deciliter. Whenever it falls below 10 gram, transfuse them. But if they are non-transfusion dependent thalassemia, they have a high risk of alloimmunization. So you transfuse only if they are 8 gram per deciliter. You have a lower threshold for non-transfusion dependent thalassemia. Because they are already exposed, they may have alloantibodies. So it's always better to be aware of this before conception and also during transfusion in pregnancy. So I already told that it is a hypercoagulated state. So continue low dose aspirin, and in those with platelet count more than 6 lakhs when they are splenectomized, we also have to start low molecular weight heparin. Fetal monitoring is extremely important to, with counseling of high miscarriage, and this as obstetricians, you know better than me. Supplements, of course, calcium, folic acid is anyway given. Also give calcium and vitamin D. May have to give at a higher doses for these people because they are already having a weak bone. During the pregnancy, the mode of delivery depends on, it's usually cesarean because they have a cephalopelvic disproportion because of this iron overload and the bone deformity that is formed. So most of the times it is cesarean, but then you can assess them and then decide. What is very important is if the patient is already having some non-transfusion dependent thalassemia, may still have a little bit of thalassemic phases, and therefore general anesthesia may be difficult. It may be difficult to intubate. I had one mother who had this problem and we had to abort general anesthesia in this child, but this was for some other surgery. After the delivery, because of high risk of thromboembolism, it is always advisable to keep these patients for at least 7 days in the hospital, mobilize them as quickly as possible, and other things, and continue the desferrioxamine as iron chelation, avoid oral chelators till the breastfeeding is stopped, and continue all the supplements that the mother needs. Most important for me is prevention of births of new thalassemia major patients, and this can be done by education, prenatal diagnosis, and pre-implantation. And this was already covered. The risk of a baby being born with thalassemia major is nearly 25%, and we want to stop that totally. CVS is done in 10 to 12 weeks, and this is the ideal time. And those who miss this time, we do advise amniocentesis. In our center, both are being done depending on the cost and so many other issues. DNA analysis, almost 80 mutations are known to cause thalassemia major. 5 to 6 to 7 mutations are the most common one. I'll not go into the details of this. Some of them do not need prenatal diagnosis if the parent is already known to have these conditions, that is HBD, hereditary persistence of fetal hemoglobin, HBD, beta thalassemia, HBQ beta thalassemia, homozygous HBD, and non-transfusion dependent HBE, which is a very mild variant. You do not need to have prenatal diagnosis because the babies born with these conditions have mild problems and can lead a normal life. Pre-implantation genetic diagnosis, the advantages is you're not only having a normal baby, but for us, if there is already a child with thalassemia major and does not have a HLA matched donor for stem cell transplant, you can select an embryo which is not just thalassemia free, but also an HLA match for the sibling. I have 3 patients, out of which one is undergoing bone marrow transplantation. This child is thalassemia major. The mother underwent PIGD and had a second child who was not just normal, but was also HLA matched with the first child, and therefore was a stem cell donor for this child. 2 have already undergone this, and the baby is normal. The child with thalassemia major is normal, and the third one is undergoing bone marrow transplantation now. But yes, it is costly. It is as costly as bone marrow transplantation, and the complications you're all aware, and maybe you people are the best people to select who are the ones, but we always send them for PIGD. In this, I would just like to say that if there is a 25% chance of having a normal child, 25% chance of having a thalassemia major,
Hello, Dr. Shobha. Dr. Shobha? Has she
I
got
think
the,
she lost her
the
network, ma'am.
Yeah, it seems so.
She lost her network.
Okay. So shall we
You just call her
conclude?
on mobile, ma'am.
She may rejoin. She's not picking up the calls. She's out of range, it seems. So, Pratima?
Yes, ma'am.
Can we ask your persons to conclude?
Yes,
She's out of range.
Yes.
Can I speak?
Yeah.
Yes, ma'am.
Yeah, Dr. Suman.
Yeah. Good evening to all. And of course, it was a wonderful journey with thalassemia from conception to birth, which was highlighted by Dr. Shobha. Unfortunately, we could not hear her concluding this topic. Madam covered everything actually: prenatal, pre-implantation, genetic diagnosis, antenatal management, as well as postnatal management. And of course, she has really refreshed our pediatric knowledge as well as the obstetric knowledge. And definitely, of course, as today is the International Thalassemia Day, and the theme for 2024 being Empowering Lives, Embracing Progress, Equitable and Accessible Thalassemia Treatment for All. That is to say that let us all ensure that all individuals with thalassemia, no matter their location or economic circumstances, receive access to accurate diagnosis, current and future treatments, and well-rounded care, which just now Dr. Shobha highlighted, and help them live their lives to the fullest. And last but not least, I would like to thank Dr. Megha Kamlapurkar, the Chairperson of Genetics and Fetal Medicine, KSOGA, as well as Pratima Prabhu, the high-risk pregnancy and fetal medicine specialist from Mangalore, who have organized this wonderful webinar on this International Thalassemia Day. And of course, it is worthwhile doing so. And thank you one and all for this opportunity given. Thank you.
Thank you, Dr. Suman. I just wanted to ask you, what is the scenario in government hospital? I mean, your government medical colleges. Is it being done free?
In our setup, in our belt, we have hardly seen any. But in my personal experience, I had 2 cases. Of course, the first pregnancy was thalassemia major. The second pregnancy, of course, they did the diagnosis by CVS, the fetus, and then that also landed up in thalassemia major, and then we advised for termination of pregnancy. And that first child, poor thing, is receiving blood transfusion every month, going to Hyderabad, and they're not very well off also. And definitely the government is helping them a lot. So it's a little bit rare, and it is in a few little community. One community is there where few cases are only there in this belt, Ballari district.
I'm asking about screening. Screening for all
We are
pregnant
not
women.
doing universal screening, madam. We are not doing universal screening here, but I think it's high time, and we should all do it.
Yeah, Dr.
But very definitely,
under your leadership, we can just give an appeal to government of Karnataka that at least it should be offered at a very concessional or affordable prices in government setups, medical colleges.
Yes, I think so. Because right now it is being done only by the Thalassemia Society of India. They do offer a lot of support in the prenatal diagnosis and all that. So if you could identify those centers in your nearby locations, that's what I was doing for those who are not affordable. We would not for the testing, but for the prenatal, if you wanted any amniocentesis or such things, we were sending them there. And whenever we used to have we have had quite a few thalassemia children, and we used to give them, arrange blood for them and give it free of cost to them. We have been doing that in our own setup. But as you said, I think the government has to wake up. And now that this year's budget, some allocation has been there for screening, we should try to ask them to percolate it into the government protocol of screening everybody. And as you said, Megha, the prices can definitely be brought down. Because I think generally few of the labs here in Hassan, some of them do it for 1,200, 300. Then I told them, no, I want you to reduce it. And they said, okay, madam, if you give us large numbers, we'll bring down to 1,700. And I heard from Dr. Chinmayi Rata in Hyderabad, they do it for around 600 to 700. So I have been in conversation with LifeCell. And I was telling them, see, if you people bring it down, all our KSOGians all over the state will definitely see it makes a lot of difference. If 400, 500 is an affordable price, they will definitely get it done. And along with that, I think we can definitely write to the government and ask them to try to tell them the seriousness of thalassemia and the implications of the health of the individual and the family. So because like
by next year we should be hopeful that by next year we will be having such facility.
And say, give them an advocacy and anything, all of us will send it to them also. We'll try
but
to.
Hassan, are you doing, madam, universal screening?
Madam, I would advise at this point of time, I'm not doing universal screening, but last month it was an eye-opener for me. And then I started asking them to do screening for everyone. I used to do it randomly for anemic patients or family history of blood, or they had blood transfusion in the pre-pregnancy state. And on those lines, I was doing it. But I think from all these situations, I am thinking of doing universal screening nowadays.
We are doing
Dr.
only in,
Pratima, can we proceed to the panel?
Yes, madam.
Sorry.
okay.
Sorry
Thank
to
you.
disturb.
Thank you.
We have very interesting panel discussion, though short of time, but we need to just highlight important points, and our panelists, they are eager to share their experience and knowledge. We have Dr.
Yes,
Malini to give it.
Moving on to our next
Welcome, ma'am.
session. Yes, we have a panel discussion on thalassemia and pregnancy. So I'll be moderating it along with Dr. Malini Yogala. So I would like to introduce her. She is done a fellowship in high-risk pregnancy and fetal medicine from Fernandez Hospital, Hyderabad, and presently working as a consultant there. Her areas of interest being adult congenital heart disease, connective tissue and hematological disorders, obstetric critical care, fetal invasive procedures, and she's very interested in training of fellows in maternal and fetal medicine, and she is instrumental in setting up protocols for high-risk pregnancy. I would also take this opportunity to tell that she is my teacher from Fernandez. I have also done my course there, and she's been one of the fantastic teachers, and it is giving me immense pleasure to introduce her to this session. Welcome, ma'am.
Dr. Pratima, you just display your CV. I'll introduce you to the
Ma'am, my CV.
Yeah, why not?
Yeah. Just a minute, ma'am. 1 minute. Yes, ma'am.
Okay, Dr. Pratima, she is a very close friend of mine after I visited Mangalore Society, and she is very lovely, and she responded to my request of just taking being a MOC for this event and being a moderator for this panel discussion. She has done her MBBS from NFI Medical College, Mangalore in 2010, and she has finished her MS OBG from SCB Medical College, Cuttack, Odisha. She has done her fellowship in high-risk pregnancy and fetal medicine in Fernandez Hospital, Hyderabad, under Dr. Malini. She has done her MRCOG, and she is FMF UK certified trainer, obstetric ultrasound and Doppler studies. And she is K2MS, Australia certified labor monitoring. She is certified in telemedicine and clinical medicine from Harvard Medical School, and she is member of various state, national, international societies of obstetrics and obstetric medicine and fetal medicine. That is maternal and fetal medicine. And her special interests are high-risk pregnancy, recurrent pregnancy loss, pre-pregnancy counseling, fetal medicine, and interventions. Presently, she is maternal and fetal medicine specialist, assistant professor, Department of OBG, Father Muller Medical College, Mangalore, and I'm very happy that Pratima, you are today with us and just moderating this panel. Welcome to you.
Thank you. Thank you so much, ma'am, for that very nice introduction. Thank you. Yeah, thank you, ma'am. Just next, I would like to introduce our panelists for today. We have Dr. Chandana Pai. She has done her MBBS from Basaveshwar Medical College, Chitradurga, and her DNB Pediatrics from SS Institute of Medical Science, Davangere. She also has qualification of MNAMS, and she has done a fellowship in pediatric hematology oncology from KMC Manipal. Presently, she is working as an assistant professor, pediatric hematologist oncologist, Department of Pediatrics, Father Muller Medical College, Mangalore. Our next panelist is Dr. Aarti Raghu K. She is a consultant obstetrician at Dr. Krishnamurthy's Hospital, Bidar. She is a member advisory committee, district PCPNDT Bidar since 2020. She is a Honorable National Treasurer FPAI HQ from 2020 to 2023. She has been a past president of FPAI Bidar. She is a member of Fetal Medicine and Genetics Committee, KSOGA from 2022 to 2026. She is a member of PSC FOXY from 2018 to 20. She is a member of Food, Drug and Medico-Surgical Equipment Committee from 2020 to 2022. She is a secretary Bidar of OBGI Society. She's been a vice president of IMA Bidar in 2012. She's been a president Rotary Club of Bidar New Century. She's a director of Global Sainik Academy Bidar, and she's a district development committee member, Art of Living from 2009 to 2013. Welcome to you, ma'am.
Thank you, ma'am.
Our next panelist is Dr. Rupa PS. She's done her MBBS from KMC Manipal, MS from KMC Manipal, MRCOG from UK, and she's done a fellowship in fetal medicine from KMC Manipal. And presently, Madam is working as an additional professor in the Department of OBG and consultant in the Division of Fetal Medicine, KMC Manipal. Welcome, Madam.
Thank you.
Next, we have Dr. Vismaya Kaveri. She has done her MBBS from KMC Mangaluru, MS from St. John's Medical College, Bangalore. She has done her DNP and she also is qualified by MNEMS. She has done a fellowship in gynec laparoscopy from RTS Hospital, Bangalore, and she is presently working as an assistant professor in the Department of OBG, Father Muller Medical College, Bangalore. Welcome, Dr. Vismaya.
Thank you.
And then we have Dr. Arjun Kumar H, consultant obstetrician and gynecologist, CHC, KM Doddi, Maddur Taluk, Mandya. Welcome, sir. So I would like to now invite Dr. Malini to start with the introduction and our first case and to share her slides.
Is my screen visible?
Yes, ma'am. Yes.
Thank you, Pratima, for the very kind introduction, and thank you to the whole of the KSOGA family for having me. It is indeed a great privilege to be part of this academic feast and to be co-moderating the panel with Pratima. Pratima, I would request you to share this. Okay, yeah, I think I can share.
You can, ma'am. Yes.
Yeah, but there's some glitch with the movements of the slides. I will stop sharing, and if you can share, then I think we will proceed with the panel. Can you do that? Yeah, while Pratima is sharing the screen, I will start off with the panel. My first question will be to Dr. Chandana. How frequently do you see the cases of thalassemia major or thalassemia, transfusion-dependent thalassemia in your setup?
Ma'am, we have a thalassemia center, regional thalassemia center, where we have a highest number of thalassemia cases in all of the Dakshina Kannada district. So we have almost 148 children and young adults coming to us every month for transfusions. They have both like thalassemia major, thalassemia intermedia, sickle thal, E beta thalassemias, and few of the RBC problems like pyruvate kinase deficiency, G6PD deficiencies, and congenital dyserythropoietic anemias also added up in this whole panel. And like we have also detected lot of thalassemia traits on OPD basis as well when they were not responding to iron therapy started by others and referred to us for evaluation of anemia. So yeah, it is not very uncommon thalassemias. We are seeing quite a good number of thalassemia children and young adults.
Do you think the spectrum is limited to particular areas or sects like Sindhis, which we have learned that is more common in the North India, or do you think this is now becoming a global problem?
We in Mangalore, as such, we have a mixed population, migrants, the laborers, who are migrated from like all the cities of Karnataka and also neighboring state like Kerala and also from West Bengal. In Uttar Pradesh, we have a lot of mixed populations. So we are seeing more in these laborer communities, especially. Yeah, it is known that in Karnataka, the special ethnic populations like Lingayats, Gaudas, and Konkanis, we have a little more higher prevalence for thalassemias. Even we are seeing the same in our setup as well.
Yeah, so like projected in the screen, most of the South India, the incidence is around 1 to 3. But if we go to the North, the incidence is very high. But then that should not be a limiting factor for us in screening because of the migration of the population and intermarriages among castes and sects that is now going on. Next slide, Pratima.
Yeah.
Yeah, so and this has been again reiterated in the two previous talks, what the impact of thalassemia major both on the healthcare sector as well as on the finances of the family. So I would not go into this for the want of time. Go to the next slide. So we'll directly go to our first case. Yeah, she is a primary gravida who came to you for booking at 8 weeks of gestation. She doesn't have any significant medical or family history. So my first question would be to Dr. Aarti Raghu. So what baseline investigations would you do routinely for any pregnant woman who comes to you, madam? Do you routinely screen for hemoglobinopathies?
Ma'am, routinely I do complete blood count, blood group, thyroid function test, then infection screen like VDRL, HIV, HPSAG. Then I do glucose challenge test, DIPSI test. And if the lady is anemic and if she's refractory, having refractory anemia, then only I do thalassemia screening. But I think miss after like reading about thalassemia and getting aware, I should be doing thalassemia screening routinely for all the ladies, because even with thalassemia, they can have normal HP. So why to miss out those ladies? So now routinely I'll be doing the thalassemia screening for all the ladies.
Yeah, so you said I mean, all of us would be doing CBC routinely for everybody. So what parameters in this complete blood counts or complete blood picture that are important? And as you yourself said, some of these women may have a normal hemoglobin. So is it still necessary to do screening for a thalassemia? Because usually even if it is a thalassemia trait, they present with anemia.
Yes, ma'am, definitely. We should be doing thalassemia screening for everybody.
Dr. Rupa?
And yes, so as already discussed previously, in many places, yeah, we might not have the pathologist, and it might be difficult to do few of the testing, but still, at least we might get some picture with the complete blood count, and in that, basically, we have to look at the RBC indices. The MCV and MCH will be low, but along with that, peripheral smear, as discussed, might give a clue. But more commonly, as they were discussing, RBC count will be normal in these patients as compared to, or high in these patients as compared to patients with iron deficiency anemia. And a normal ferritin or the transferrin saturation is a very big help in diagnosing this. And as already told, these patients can have near normal hemoglobin, so it is necessary to do the carrier testing.
The hemoglobin levels depend upon the type of mutation. So they may be having a hemoglobin more than 10, 11 also sometimes. So we cannot just base it based on the hemoglobin levels. And as already pointed out, the MCV, MCH, MCHC, next slide, Pratima, the retic count. So these give us a picture. And as I can see here, these are the target cells. So in the peripheral smear, these are pathognomonic for thalassemia. So to differentiate between iron deficiency and thalassemia minor, especially, we look at MCV, MCHC, the RBC count, and the red cell distribution width that Dr. Shobha was talking about, which is increased in case of iron deficiency anemia, which may be normal in thalassemia. So just looking at the complete blood count, we will have an idea about the hemoglobinopathy status for these women. So Dr. Arjun, next I would like to ask you, what are the tests that are available for screening for hemoglobinopathies?
I think sir is not there. Can't see sir. I think sir is not logged in, madam.
Okay. So Dr. Chandana, can you take this question?
Yes, ma'am. So screening for hemoglobinopathies is one is the RBC's indices, and then is Nestrov's test, which was routinely done in the previous years. But nowadays, with better available and quick methods for diagnosis as well as screening, we don't do it routinely, Nestrov's test. And also the most like important gold standard one is HPLC. In a centers which don't have HPLC, HPA electrophoresis also gives the similar information, which is good enough.
So the Nestrov's test is a osmotic fragility test that can be very easily done. And as you told where the facilities are not available, where we may not get the indices or we don't have a pathologist to do a peripheral smear, then this is a very simple test that can be done, especially in the rural areas. Next slide, Pratima. So I will skip this question. Next slide. So you talked about, Dr. Chandana, you talked about HPLC and hemoglobin electrophoresis. So what parameters are important in this and how would you read the report?
Yeah, so as highlighted by all the other speakers, so we would be looking for the HPLC or HP electrophoresis, would be mainly looking for the HPA, HbA2 and HbF values. So normally adult hemoglobins will have HPA and minute value of HbA2. So normal HPA will be 95 to 98% is a normal value of HPA. And HbA2 generally between 2.5 to 4%, and each labs has to have their cutoff value for HbA2. Generally, it is 2.5 to 4% is a normal values. HbF is maybe 0 or up to 1 to 2%. And we don't see other windows like HPS, HPC, HPE windows are generally not present in the normal person hemoglobin. So we will first concentrate on the hemoglobin A, HbA, the percentage of HPA. So if the percentage of HPA is less, and we will next look for the HPF, which is the other hemoglobin which is taking up the place of HPA. So HPF, if it is like more than 50%, then whether it decide the status of the, depending on the HPA, we will decide whether it is straight or it is the major or the intermediate. And HPA2 levels always tells us the diagnosis. Only the HbA2 levels will be more in thalassemia trait or the minor. So HbA2 levels always more than 4% is the diagnosis of the thalassemia trait. And HPS window, HPE window additionally will diagnose other hemoglobinopathies.
Yeah, so this is the approach that we have all the previous speakers and Dr. Chandana also has emphasized upon. So you have to look at both the red cell indices as well as the HPLC to arrive at a diagnosis. So coming to our case, so we have done a HPLC. This is our HPLC for the our current booked woman. So the HbA2, HbA is 83.8, F 1.1, and A2 is 4.6. So the HbA2 value is elevated, and then we have come to a diagnosis that she is a thalassemia trait. So what is our next step? Dr. Vispaya, can you please elaborate on that? So the woman is now thalassemia trait. How do we proceed?
Since she's a thalassemia trait, we would like to evaluate her partner to look whether he is a heterozygous or homozygous. So we would want to do HPLC for the husband. And once we do the HPLC of the husband, we will get to know his status.
So this is the HPLC report for the husband, Dr. Vismaya.
Yeah, so in this report, since HbA2 is more than 4%, it depicts that it is a carrier state. It is thalassemia trait. So since both the husband and wife both are trait, and this is an autosomal recessive condition, they have 25% chance of the child being affected and 50% chance of being carriers and 25% chance of child being not affected.
Yes, thank you. So here, go back to the previous slide. Yeah. So here, both the couple are carriers. So, but we have to realize that this is the 25% risk of fetal major, and the risk is there for each pregnancy. It is not for the couple for their reproductive life as a whole, because many of the patients who come to us, they think that, okay, previous child is thalassemia major, now my risk is over, this baby may be normal. No, this the recurrence is each for every pregnancy, and we'll, so we have to drive home that point and educate the couple in that manner. So next slide. Yeah, Dr. Rupa, now that both the couple are carriers, how would they have come to you? We have sent them to the fetal medicine specialist. How are you going to proceed with counseling and management of this pregnancy?
So as such, now we know the fetal risks. Ideally, it would be best to do a molecular diagnosis and have that mutational analysis testing of both the partners. I mean, of the couple as such, so that we can go ahead with the this one prenatal diagnostic testing, which will actually include the CVS and amniocentesis. But ideally, CVS would be a much better testing because the quantity and the quality of the DNA for the molecular diagnosis is much better, and we will get an early result, and our in terms of if they have further management in terms of termination of pregnancy, if it is this one affected pregnancy, can be taken.
But can we directly do invasive testing before doing a HPV gene analysis?
Ideally, as it is like we will, it is very difficult to get what is the point mutation which is causing. So ideally, if you want to go by ideal, it would be better to test both the parents and then go ahead with the molecular diagnosis in the fetus.
Agree with you, ma'am. So a diagnosis of the mutation in the couple is important, and targeted gene analysis in the prenatal testing sample is very important. Otherwise, we'll be just searching for the needle in the haystack. Sometimes we may not be able to just identify the mutation by just sequencing. We may need to do a deletion duplication analysis. And so initially we would look for the most 5 common mutations that are known to occur in India. And if we are not able to identify that, then we'll go, our search would continue for the other rare mutations. But identifying that mutation and targeted gene testing in the fetus is always the way to go. So we have done the HPV gene analysis for both the couple, and we found the same gene mutation in intron 1. So how do we proceed next? What Dr. Rupa has already suggested that we do a CVS over an amniocentesis, and the advantages of the CVS over the amniocentesis, Dr. Rupa has already told. Next slide. So we do it at an earlier gestational age, and we have a better DNA extraction. And we have time to carry out any interventions, that is termination at an earlier gestational age if the fetus is affected. That is the advantage of doing a chorionic villus sampling. So can we offer an NIPT?
So at present, NIPT is still in the experimental stage as such, and it is still a screening as such. NIPD as such has not come into picture, at least. So we would not ideally like to do an NIPT for this.
Yes, there are only studies coming up with very few sample sizes. But yes, that needs more research before we can regularly offer an IPT to these couple. And Dr. Aarti, is there a role for pre-implantation genetic testing?
Yes, definitely, ma'am. There is role of pre-implantation genetic testing, but here the couple is already like pregnant. So maybe in the next pregnancy, they can go for pre-implantation genetic testings, if they want to avoid the abortions. And also, if a current baby is affected and they have aborted already, then it will be like a psychological trauma for them. So for the next pregnancy, they can go for PGT to diagnose it earlier.
Yeah, especially if they have other indications for an IVF, then we can definitely offer a PGT. But then again, it has its own limitations, the cost being one of the most important limitations. So coming back to our case, we have done a CVS. So the possible results for the fetus can be that it can be unaffected in 50% of the cases, or it can be a thalassemia trait in 25%, and thal major in almost 25%. That is, if it is a homozygous for the mutation, the fetus can be affected with the thalassemia. So, but luckily, our fetus, the report showed that it is there is no pathogenic or likely pathogenic variant that is causative, and we have to, this is very important, that we have to rule out the presence of maternal cell contamination in the chorionic villus sampling. This is also very important, that we should send a sample for maternal cell contamination as well when we are doing the CVS. So next question, to again Dr. Aarti. So how do you manage anemia in this women with beta thalassemia trait?
Ma'am, usually this beta thalassemia, they are with iron deficiency also. So if the ferritin levels are low, then we can treat the anemia with iron supplements, folic acid supplements, and even B12 if the anemia we find it is dimorphic or refractory with iron alone.
Yeah, so
And,
serum ferritin, yeah, and iron studies, they will help us in guiding the direction. If the serum ferritin is normal, only folic acid will suffice. And but if the serum ferritin levels are low and iron binding capacity is high, we can give oral iron supplements. But we have to be very cautious before giving injectable iron. Many times, especially women coming from the districts, they have already received injectable irons for the treatment of anemia with no response to the treatment. That is the most common scenario that we usually see. So please do not give injectable irons without knowing her hemoglobinopathy status. This is one of the important points that I would like to emphasize upon through this panel. And blood transfusion should always be be our last resort, especially in severe anemias. Okay, so we have the NHM policy for prevention of hemoglobinopathies, where they where they advocate universal screening for all antenatal mothers, and if they are identified as thalassemia trait or any other hemoglobinopathies, extended family screening. They emphasize upon premarital and preconceptional counseling backed by genetic counseling services, community education and awareness programs, and sustainable and cost-effective carrier screening programs at the school level is also being advocated by the National Health Mission. So this will conclude our first case, where we wanted to especially to stress upon the screening and the prevention aspect of having a child who is suffering with a hemoglobinopathy. So our next case, we will be dealing with a woman who is actually suffering with a transfusion-dependent thalassemia and who is pregnant. Because of the establishment of these thalassemia societies, due to advances in the iron chelation therapy, and our pediatricians and hematologists managing these women, these children very well into the puberty and into the childbearing age. We are finding more and more women with these transfusion-dependent thalassemias coming to us with pregnancy. So the second case, we'll be dealing with that. So I would hand over this case to Dr. Pratima.
Thank you, ma'am. Coming to our second case. She's a primary gravida who was referred for booking in view of sickle beta thalassemia and pregnancy at 10.6 weeks of gestation. She's a known case of sickle beta thalassemia, and she has history of blood transfusions every month since the age of 5. So my question to Dr. Chandana, what is sickle beta thalassemia, and what is the interaction between different hemoglobinopathies and beta thalassemia, and where all is prenatal diagnosis indicated? Chandana?
Yeah. So sickle beta thalassemia is a inherited form of sickle cell anemia or sickle cell disease, which affects the RBCs, wherein there is both defective in the production of the quality and also the quantity. So this is usually caused by compound heterozygous mutation, wherein one of the abnormal gene comes from the father and another abnormal gene carrying either thalassemia or sickle cell anemia comes from the mother. So the individual will express both these genes together. That is why it is called compound heterozygous and manifest both the symptoms. And coming to the interactions between the different hemoglobinopathies on beta thalassemia, we usually see beta thalassemias are in association with other hemoglobinopathies like HBE, HBC, HBS. HBS is sickle, so HBS, and also like few of the rarer forms in a few geographic areas like HBD Punjab, HB Lahore, and HBO Arab. These are the usual associations we have found along with the beta thalassemias. And as highlighted by Shobha Bedegar ma'am, this is prenatal diagnosis is not indicated in all these forms because many are like milder forms which doesn't require prenatal diagnosis. We requires, which in this case especially one person is a carrier of sickle, and the other person, other parent, other person is a carrier for any of these, like HBC or HBD or your HBS or HBO Arab. These are the things, severe forms which requires prenatal diagnosis.
Yes, thank you, Dr. Chandana. So we know that sickle beta thal, we have here quantitative as well as qualitative hemoglobinopathy. It is a kind of. So in this, we have basically two types: sickle cell beta 0 thalassemia. Here there is no HbA production, and it is similar to sickle cell anemia, moderate to severe anemia they have. So our patient was of this kind. And then we have sickle beta plus thalassemia. So it is a milder variety. And so this is a slide from RCOG. So it says that whenever there are beta thalassemias, HBS, HBE, delta beta thalassemia, HB lipo, HBO Arab, or HB constant spring, so there is serious risk of hemoglobinopathy, and we should offer prenatal testing in these kinds of hemoglobinopathies. So next question to Dr. Rupa. We would like to see her pregnancy. We would like to see her in the pre-pregnancy period and not after conception. So what evaluation would you like to do, and how would you optimize her condition before conception?
So yes, ideally we would like to see her in the pre-pregnancy period, and ideally it would be, as discussed till now, it would be in the pre-marital period before she before she marries. If we have a testing of the husband or her partner, that would be the ideal situation which you would want for. And if in such cases, she should know also, the couple should know that because of her status as such, basically because of the repeated iron transfusion and end organ damage because of the iron overload, there might be a chance that she might not, there might be difficulty in fertility, difficulty in conception, requirement of artificial methods for conception as such, and the fetal risks involved with depending on how the partner, status comes into picture. And then coming to the pre-conceptional counseling after marriage, again, partner testing is again very important. And depending on that, we would again counsel her on her risks to the fetus and what her plans on conception are. If ideally they would not like to conceive, good, even though there is fertility, ideally contraception would be advised in them. And once if she plans to conceive, then it would be best to optimize her in terms of decreasing the iron overload, giving aggressive chelation therapy, so that basically the end organ damage, as discussed, on the heart, liver, and the end organs, endocrine organs comes down. And if that is achieved, then the problems basically in terms of mortality and morbidity for the mother and the fetus would come down. And ideally we would like to get the ultrasound, at least we had this cardiac screening and the liver screening for the iron overloads, to see that it is in the optimal level before she conceives.
Thank you, ma'am. So it is not only pre-pregnancy, it is pre-marital counseling which you would like to do. So it has already been highlighted and told by the previous speakers too. So we have to evaluate the partner. We have to look after the fertility issues, the iron overload, the end organ damage like the heart, liver, endocrine functions, infections, and also we have to look for thrombophilia. So Dr. Vismaya, in this patient, what investigations would you do?
Yeah, so as already been explained, ideally would have been to do it prior her pregnancy, preconceptionally. In case that has been missed, then when she has conceived and she's come to us, I would like to do a hemoglobin level, as she's transfusion dependent, hemoglobin status and ferritin levels. And then as this condition affects the end organs, endocrine organs and other organs like heart and the liver, I would like to evaluate for the same. So screen for diabetes, ensure the thyroid status and vitamin D levels, and then go ahead with ECG, 2D echo, and if affordable, cardiac MRI as well to look for the cardiac overload. and scan of the liver to look for iron overload, and ultrasound abdomen to rule out cholelithiasis as they are prone for gallstones. And since she is transfusion dependent and can be increased chances of viral hepatitis or aluminization because of multiple transfusions, we need to screen for the same. In case the partner screening has not been done earlier, then we have to go ahead with the partner screening with HPLC. And also, when she has come with pregnancy at 10 weeks, we have to go ahead with USG for fetal viability and dating.
Well said, Dr. Vismaya. So this is the patient's report along with the family members. So the patient's report here, we can see it is sickle beta thalassemia trait. Her mother was beta thalassemia trait. Her father was sickle cell trait. Unfortunately, she received both of this and she has become sickle beta thal trait. Luckily, her husband HPLC is normal. So, Dr. Aarti, can you tell me what is the risk of inheritance to the fetus in this case?
Ma'am,
the mother?
It means all the babies will be carriers, ma'am, but no
Yes,
baby
correct.
will be affected in this.
Yes. So half the children will be sickle cell trait and 50% risk of the children having beta thalassemia trait. So all will be traits and none of them will be affected majorly. So we do not have to go ahead with prenatal testing in this case.
Yes, ma'am.
So coming back to our case, the total bilirubin was slightly higher, 3.4. The ferritin levels were high, 5,821. The ultrasound abdomen and echo was normal. So, Dr. Rupa, can you tell me the role of iron chelators in pregnancy and what is their safety profile?
So, iron chelators are not safe in pregnancy except for that desferoxamine, which is usually, again, the safety data on this is not available during the organogenesis period. So, ideally, they would, in case you think that the patient requires that, ideally after 20 weeks onwards, iron chelation therapy in pregnancy is advised. Or else, what other chelators she was on pre-pregnancy, ideally it would be stopped 3 months prior to her pregnancy before she conceives.
Yes, ma'am. So, deferoxamine and deferriprone, they are to be discontinued 3 months prior. Hydroxyurea should be stopped 3 months prior. And desferoxamine is the only chelator which is category C in pregnancy and can be used. That too after the first trimester. So there is lack of safety data regarding the iron chelators in pregnancy. There is a small risk of skeletal abnormalities and delayed ossification. This has already been told by Dr. Shobha and can be used in second and third trimester. Dr. Rupa, can you please take up this question? What is the risk of the fetus and how do you monitor?
Yeah, so actually these babies are at a risk of, one is she can have abortions in the first trimester and in the second, going on into the second trimester. And these babies are more at a risk of fetal growth restrictions. And ideally, after 24 weeks onwards, a growth with Doppler would be ideal for these fetuses. We will not talk about that prenatal because anyway, this baby is either, it will not be affected, it will be just a carrier state at the most. Yes. And there is a chance as the pregnancy advances, one is preterm birth and stillbirth.
Hello?
Yes, yes.
Yes, ma'am.
Yes.
So we have to do, other than the routine scan, serial growth monitoring in these fetuses, and we have looking for the ICT in the mother. So if it's positive, we have to suspect isoimmunization, and we have to keep the fetus for follow-up for fetal anemia by using MCA PSV values. Dr. Vismaya, can you tell me how do you manage anemia in this mother and what are the target hemoglobin levels?
Yes, ma'am. Since she is transfusion dependent, we have to evaluate her hemoglobin level first. And if it is less than 10, we have to consider transfusion to maintain the target level of 10 gram. And we'll have to repeat the hemoglobin once in 2 weeks. And depending on the hemoglobin level, we will have to consider transfusion every 2 weeks or as required. And the type of blood transfusion would be cross-matched and leukodepleted would be preferable.
Yeah, and only 1 pint per transfusion, so not more than 1 pint.
Yes, yes, ma'am.
The rationale being, we are going to dilute the sickle's RBCs and suppress the erythropoietin release, decrease the percentage of HBS containing cells, and increase the oxygen saturation of the hemoglobin. Dr. Aarti, when do we plan her delivery and what is the preferred mode of delivery?
Ma'am, if the baby is growing well, we should be delivering her ideally after 37 weeks, between 37 to 39 weeks maybe. And we should prefer vaginal delivery unless there are other obstetric indications that we should.
Right. Yes, correct. So, Dr. Rupa, can you tell us about the interpartum management in these mothers?
Yes. So as discussed, obstetric indication is the only indication for cesarean section. So we would ideally try for a vaginal delivery. In such cases, these women need to be, they are at a higher risk for either the sickle cell crisis or hypoxia-induced crisis also. So basically they should be well hydrated. Hypoxia should be avoided. They should be connected to the monitor. Might be oxygen also might be supplemented. And they would also, as discussed, ideally they told about this one, propped up position and good analgesia. Okay, in such cases, we might advocate, though routinely, ideally in such cases, epidural analgesia would be the ideal this one, analgesia in this case. And along with this fetus is at a risk of sudden IUDs or stillbirths. So continuous fetal heart rate monitoring. And because of the iron overload, you have to give desferoxamine 2 grams IV over 24 hours as she goes into labor. Avoid prolonged labor as such, because that also might increase her risk. And active management of third stage of labor when she delivers to prevent postpartum hemorrhage.
We are going to prevent because she has both elements of sickle cell as well as thalassemia. We are going to take precautions for both. We are going to keep her warm with fluids and analgesia. And as you said, in transfusion dependent women, we have to use IV desferrioxamine. So, Dr. Aarti, can you tell us about the postpartum care?
Yes, ma'am. This lady should be in the hospital for at least 7 days postpartum. And again, in the postpartum period, we have to avoid hypoxia. We should keep her warm because hypothermia again can be a problem for her. Then thromboprophylaxis can be given if she delivers normally till 7 days postpartum. And if she is like cesarean, then 6 weeks after cesarean, the thromboprophylaxis should be continued. And there is like increased chances of thrombotic activities, DVT. So she should be on the DVT stockings.
Yes. So we have to use heparin, especially in this patient, because sickle cell component, it can lead to thromboembolic risk. So we have to use low molecular weight heparin. Dr. Vismaya, can you tell us about the contraceptive advice? It's already been discussed in the previous speakers.
Yes, ma'am. So as estrogen component is thromboembolic, it precipitates, so we should avoid estrogen component in the contraception, preferably progesterone only pills or Mirena, that is intrauterine system, would be preferable and ideal, as copper T sometimes can increase the bleeding and which may be detrimental for her, causing further anemia. So ideal would be Mirena insertion if she is willing, or go ahead with sterilization if she has completed her family.
Yes, correct. So progesterone, it can be pills in the form of injection. They form the first line along with Mirena, and the second line is the estrogen containing pills and the copper T. Dr. Chandana, so can you tell us about the care of newborn in this mother?
In this index case, the babies would be either sickle trait or the thalassemia trait, where the care of the newborn will be as normal as any other baby. But keeping IUGR and both restrictions in mind, we have to give the normal routine newborn care. Along with that, adequate hydration, avoid extreme temperature fluctuations, and also avoid hypoxia. And these, if there are babies sickle carriers, they are at risk of high infection. So high hand hygiene and infection control plays an important role. And if the mother is alloimmunized, baby is at risk of hemolytic disease of newborn, which has to be managed like any RH incompatibility or any hemolytic disease of newborn by phototherapies, IVIGs, hydrations, and all. And screening, coming to the screening, when we don't know the partners, or when we have the mothers coming to us for the deliveries, when we don't know the status and prenatal diagnosis testing and all not done, that time we always screen the neonate cord, take the cord blood for neonatal screening for sickle thalassemias and sickle cell anemias, and also combinations of sickle beta thalassemias. So by this HPLC method, or else we can have this Guthrie cards test, which is available everywhere. So which is taken as a heel prick blood sample, and which can be sent for HPLC or DNA analysis as well. And if this thing initial HPLC is normal, which usually rules out the sickles at birth, and since the fetal hemoglobin is present till at least 4 to 6 months of age, to detect the carrier status of the this thalassemia trait, we always have to repeat the HPLC after some 6 months of age or so. Usually till the HbF hemoglobin is there, usually the neonates will be asymptomatic in both sickle trait and also in the thalassemia trait cases. And immunization should be complete, not just the routine immunizations. They should include all these optional vaccines as well. Taking infections like hepatitis A and pneumococcal infections, Hib infections, meningococcals. So all these things plays a definite role, and it has to be primed during the time of delivery and during the hospital stay itself. And also this babies has to be regularly followed up and has to be explained in detail about the anemia crisis, hemolytic crisis, and also frequent infections and growth and development, and also the iron overload status in cases of sickle beta thalassemias, which has to be monitored in the routine visits.
Thank you, Dr. Chandana, for that elaborate answer. I would like to invite Dr. Malini to give the take-home messages. Madam?
Before we go to the take-home messages, I would like to add 2 more points. One thing is about the psychological issues with the couple or with that the family faces, leave alone the burden of repeated blood transfusions and all the chelations and all those things, and they'll have a lot of worry about their offspring being affected and how they can carry on their parenting. So always remember about the perinatal mental health issues and offer counseling wherever the facilities are available. That is one thing. And whatever we talked are the ideal case scenarios, where all the facilities are available. But most of the times, the women who come to us, they may be from a low socioeconomic status. They may not be able to afford, whatever the investigations we are, or whatever the treatment that is be it iron chelation or be it repeated blood transfusion. Sometimes their blood may not be available. The case that we just discussed, she is incidentally also RHIS immunized. She's anti-D and anti-C positive. So she always had to have a leukodepleted anti-C negative, anti-D negative. But most of the times that blood was not available for her. So these are all the challenges that we face when we are taking care of these women. And also the pertaining to the iron chelation, the desferrioxamine, usually that is almost supplied by the Thalassemia Society. Sometimes if the drug, they run out of stock, they may go for months together without any iron chelation, which may add to the risk for the iron overload and also risk in the pregnancy. So these are all some of the practical points that we always have to keep in mind when we are dealing with these women. So always prevention is always better than cure. So screening and prevention will bring down the number of births of affected children. So this starts with the screening test, the correct interpretation, and we need not go for a very high funder test. The screening starts right from the complete blood picture, looking at the red blood cell indices as well as the peripheral smear. And pre-marital and pre-pregnancy screening and counseling is also very important. The awareness about the thalassemia and discouraging consanguinity. This is also one of the very important things. If at all they come to us in the premarital stage, then genetic counseling, prenatal diagnosis, and offering therapeutic abortion. As one of the speakers were telling, when only if they have an option open for a therapeutic abortion, then doing a prenatal diagnosis would really help. There may be a couple, maybe because of their religious beliefs, they do not opt for a prenatal diagnosis. So these are all the prongs for us in screening and prevention of this thalassemia. And coming to the when we are taking care of the women who are transfusion dependent thalassemia and pregnancy. Next slide, please, Pratima.
Yes, ma'am.
So a multidisciplinary, multidisciplinary team care. Again, it starts with the premarital counseling, folic acid, partner screening, genetic counseling, and prenatal diagnosis where indicated. And screening for infection, hypoxia, acidosis, stress and dehydration during labor, and postpartum thromboprophylaxis, and care for the newborn and long-term contraception. These are all the points that we have to remember. And of course, the perinatal mental health issues in these women, if we have to take care of these women with transfusion-dependent thalassemia. So on this Thalassemia Day, let us work hard along with the government to take care of it in prevention and in implementing universal screening and also taking care of these women. Thank you so much for making me a part of this
Dr.
panel.
Malini,
Yes.
Malini, I just want you to add an important message that these thalassemia ladies will need to have for rest of their life, like caring themselves to avoid dehydration, strenuous exercises, and vitamin D deficiency avoidance because of taking care of her bone health. So we need to reschedule her visit after postpartum visit, and during that time we need to spend some time and tell about her lifestyle management in her future life.
Totally agree with you.
Dr. Shobha is with us. Dr. Shobha? Dr. Shobha is still with us.
Yeah, hi. Sorry. Yeah.
Dr. Shobha, please switch on your video and please suggest if you have any points to add to this. Dr. Shobha?
Sorry, I was somewhere else. Can you hear me?
Yes, yeah.
Yeah, most of the things were already conveyed and emphasized by all the panelists and the speakers. So the aim should be not just to treat, but to prevent. So this Thalassemia Day is to focus on prevention. And of course, treatment is going on, but to prevent also. One thing I wanted to stress, which I also put in the chat box, is in our country, there is a lot of consanguinity in marriage. So second degree consanguinity is very, very common. And so while doing this prenatal testing, it should be emphasized to the parents that we are testing only thalassemia or sickle genes. So the parents should fully be aware that the genetic report that comes will tell whether there is thalassemia or not, whether there is sickle cell or not, but it will not talk about other genetic disorders. So I have had a couple of patients who have had prenatal diagnosis for a particular disease, one of them being thalassemia, but the baby happened to have some other genetic disorder. And they could not believe that the genetic test did not show anything about the the disease that the baby was suffering from. So it was very difficult for me to make them understand that the prenatal diagnosis was for thalassemia only and not for other things. So whenever you have the opportunity, take a detailed history and find out if there is consanguinity. And if there is consanguinity, clearly tell them that this particular test is targeted to detect thalassemia only. and also tell them that there are ways. If we do a whole exome sequencing, for example, then we can find out if there are other genetic disorders also in the baby. Like I had one couple who were well aware that they had thalassemia traits, and before the first pregnancy, they got all the tests done. And in the first pregnancy, they even got a timely prenatal diagnosis, and the fetus was found to have no genetic disorder related to thalassemia. When the baby was born, by the time the baby was 3-4 months, she had severe diarrhea, skin rashes. And when I was called, I said, this is PID. And when we did the genetic test, it was a very rare primary immunodeficiency disorder. So we did not have thalassemia in the baby, which was looked for, but unfortunately we missed the other genetic disorder, which is quite common in consanguinity. So whenever it is possible, it's a few thousands more than prenatal diagnosis for thalassemia. So if we can, as obstetricians, it is my actual request that if you can actually tell them that this particular test is only targeting thalassemia. So if it would be better to screen all the genetic disorders as much as possible. And there is still 1% error. There was one more couple in whom the prenatal diagnosis came to be normal, but the baby was thalassemia major. So there is a 1% chance that there can be an error in the report. That also has to be emphasized so that the parents will still be able to accept if the genetic report is not what actually is there in the baby. This is one thing I wanted to add.
Thank you, Dr. Shobha. How did you feel joining this webinar of an obstetrician?
Yeah, it was a very learning experience. Actually, I had made a PPT completely about pediatric thalassemia, how to diagnose, how they present, everything. And then when Dr. Megha put a message, are you talking about counseling also? Then I realized, and then I asked, who are the audience? And she said, it's obstetrician. Then I realized for obstetricians, what will they do knowing in so much depth about pediatric thalassemia? So I changed the PPT and I really learned a lot of things, which were actually an eye-opener for me also. Thank you for the opportunity. Very interesting and nice to interact with you all. Thank you.
Thank you so much. Dr. Pratibha?
Yes, ma'am. Shall we end, ma'am?
Yes.
So coming to the end of this interesting webinar, I would like to thank one and all. To begin with, I would like to thank our chief guests and guests of honor today for their valuable time and their excellent talks, their insights. Thank you. My special thank to Dr. Megha for planning this wonderful webinar and giving me an opportunity to be a part of it. Thank you, all the speakers, chairpersons, moderator, panelists, and the entire team. Special thanks to Corona Pharmaceuticals for having organized this webinar and the IT team for their technical support. And a big thanks to one and all, the audience and the delegates who have been watching us and are with us. Thank you, one and all.
Thank you so much. We are 11 people left, and I think it is the speaker who is benefited most than anybody else. So we are still happy and enjoyed each and every moment of this webinar. Yeah, I'm really thankful to all this young generation to see that their brilliant approach. I'm very happy and I'm very hopeful also that we'll be able to conduct more and more webinars on these topics. And thank you, Dr. Malini, for your wonderful contribution to this webinar. Hope to have more cooperation from you for our future webinars. Thank you so much. Thank you, everyone.
Thank you.
Thank you
Thank you
so
for the
much, ma'am.
opportunity.
Thank
Thank
you.
you, Dr. Megha.
Thanks.
Thank you, ma'am.
Thank you all.
Thank you, Shanta ma'am. You are there till end.
Yeah,
You are
I wanted to
mute.
listen. This is the most difficult subject. And we have so many gynecologists, they are not aware of the thalassemia screening and all that. So I wanted to listen it. Thank you.
Thank you. Thank you, ma'am. Thank you so much.
Thank you, ma'am. Thank you for the opportunity. Thank you.
Thank you, Aarti. Thank you.
Good
Bye-bye.
night.
Good night.
Good night.
Thank
Good
you,
night.
Pratima
Good
ma'am.
night.
Thank you,
Good
Malini
night,
ma'am.
ma'am.
Thank you, Shanta ma'am. Thank you, everybody. Thank you.
Thank you, everyone. It was nice interacting with you all. Bye-bye.
Thank you, Pranjan, Corona team.
It's my pleasure. It's my pleasure, ma'am.
Thank you. Thank you so much.
Should I disconnect, ma'am?
Sure, sure. Thank you. Thank you.
Okay. Okay, ma'am. Good night.